So trisomy 18, Edwards syndrome, second most common pattern of human malformation after Down syndrome, and it has mental retardation, low set malformed ears, and then clenched hand, index over third, fifth over fourth. So index is over the third and the fifth, okay, like this, and this is clenched hand, and it has sternum is short, okay. Then we have VSD, ASD, PDA, cyanotic lesions, and rocker bottom foot, feet, hammer toe, okay, and what is this? Okay. And omphalocele. These are the important things. Omphalocele and Edward 13. It's client hand, short sternum, rocker bottom, feet, hammer toe, omphalocele. Then naturally see many spontaneous abortions. Feeble from birth, most do not survive first 12 days. Then we have trisomy 13, Fetal syndrome. Fetal is a defect of mid-phase. So this is the defect of mid-phase. So mid-phase development problem will be mid-phase development. So we will see the holoprosencephaly, other CNS defects, eye, forebrain development problems with that. And single defect in 3 weeks, development of precaudal mesoderm, it involves older maternal age. Trisomy 18 was Edwards, and yes, it also had the maternal age, non-disjunction. Trisomy 13 also has this. Okay, scalp defects in parietal occipital area, cutis aplasia. Okay, this is the problem with that. So basically everything with mid-face, with eye, with brain, holoprosencephaly, yeah, forebrain. This is what's happening. And severe cleft lip palate or both. Then post-axial polydactyly, okay, more fingers than that. So this doesn't have any rocker feet or these things. Just 13 just has the holoprosencephaly, mid-face problems with mid-face, eye, forebrain, cleft lip palate, post-axial polydactyly. And then another important thing is single umbilical artery, and we see the placenta. So these are the things in Down syndrome, how we can differentiate from Edwards. Aniridia, Wilms tumor association, Weger syndrome. So this one was aniridia also as Wilms. Weger syndrome is deletion of 11p13. Wilms, then aniridia, Q and abnormalities, and MR. This is Weger. Okay, Q and MR. Okay, Q, MR, aniridia, Wilms. Highest risk of Wilms compared to independent aniridia. So the highest risk of Wilms. This is just Weger syndrome, association syndrome. Then we have Klinefelter syndrome, XXY. This is most common finding manifested at puberty. IQ is decreased and behavioral psychiatric problem. Long limbs is the characteristic. Slim, so weight is to height ratio is low. Hypogonadism, hypogenitalism. So testosterone replacement at 11 to 12 years, and hypergonadotrophic hypogonadism, meaning that there's increased FSH, LH, and decreased testosterone. Okay, so they are when they are low, then FSH and LH become increased. Infertility in almost all, and gynecomastia. Okay, very important feature. Hypogonadism, hypogenitalism, but hypergonadotrophic hypogonadism. Okay, then we have Turner syndrome, XO. Gonadal dysgenesis is not evident in childhood, so chromosomes are bonded in any short stage of female whose phenotype is compatible with Turner. Okay. Also consider in any adolescent with absent breast development by age 13, pubertal arrest or primary secondary amenorrhea with increased FSH. Okay. Same increased FSH. In absent breast development by age 13, pubertal arrest or secondary primary with increased FSH. Then we have genetics. Family sporadic, no older maternal age, paternal chromosome more likely to be missing. Many mosaic patterns including Y chromatin And then small stage of female congenital dysgenesis, peak obese. This is very important. Average IQ 90, congenital lymphedema, residual puffiness over dorsum of fingers and toes. Okay. Then we have broad chest, wide space nipple, we call it shield chest, low posterior hairline, webbed posterior neck because of lymphedema. Webbed posterior neck and low posterior hairline. Cubital valgus, elbow and other joint problem. Okay, cubital valgus is in Turner's, horseshoe kidney, other renal defects. We have cardiac bicuspid aortic valve. This is the number one cardiac anomaly in Turner's, bicuspid aortic valve and then coarctation of the aortic stenosis, MVP, hypertension common even without cardiac or renal disease. Primary hypothyroidism, mostly autoimmune and other autoimmune disease, celiac disease. Natural history is decreased height velocity with delayed bone age. Estrogen treatment is indicated in increase height by 3 to 4 centimeters with growth hormone. Okay. Okay. Fragile X syndrome. Fragile X is like long arm of X in the affected male and some carrier females. Molecular diagnosis variable number of CGG. CGG preferred diagnosis DNA based molecular diagnosis. X-linked dominant males, most common form of cause of inherited mental retardation is fragile X. Girls have lower number of trinucleotides, so normal phenotype, but may have lower IQ. Findings mild to profound mild retardation, learning problems. Everything is large here, large ears, large jaw, long face, large testes, mostly in puberty. This is called macroorchidism, but they are fertile. Okay. Natural history is normal lifespan. It has something to do with ADHD, like the sister will be with ADHD or something. And early overgrowth with associated defects. Beckwith-Whiteman syndrome. Genetics usually sporadic. It's everything is hypertrophy. Microsomia, microglossia may need partial flossectomy. Pancreatic beta cell hyperplasia, excess islets, hypoglycemia. Hypoglycemia may be refractory. Glucose control is most important initial management. So everything like I have yes, hemihypertrophy. This is increased risk of abdominal tumor. Outside of the body is like hypertrophy. So it also has invalocele. We also heard this invalocele in Edwards. So microsomia, macroglossia, and hemihypertrophy and hypoglycemia because of pancreatic beta cell hyperplasia. Management is obtained ultrasound and serum. This is important. Ultrasound and AFP every 6 months through 6 years of 6 years of age to look for Wilms and hepatoblastoma. Okay. Then we have okay every 6 months to 6 years. Okay, so till 6 years we are taking ultrasound and AFP to look for Wilms and hepatoblastoma. Unusual brain and or neuromuscular finding with associated defects. This is Prader-Willi syndrome. Most with deletion 15q11 q13 imprinted segment. 15q11 q13. Okay, so paternal is responsible, hence P. P is for paternal and Prader-Willi. Same deletion causes both Prader-Willi and Angelman. Angelman was her happy puppet. This is just hyperphagia. This may be due to normal process of imprinting, which is epigenetic. Change in chromatin and not the gene sequence. Silencing due to hypermethylation of certain genes in either the male or female germ cells. The allele in the opposite germ line are expressed and therefore in the zygote. This results in monoallelic gene expression. So that for any imprinted segment, there is a functional haploid state. This established in the germ line and maintained in all somatic cells. If the deletion occurs in the male germ cell, the inheritance is from the overly expressed genes, which are maternal. So this is Prader-Willi. If the deletion occurs in female, then the inheritance from only expressed genes, which are paternal. This is Angelman. Okay, then Angelman is female and female deletion and predabilized paternal. Negligible recurrence risk and findings are first year, difficulty feeding with poor growth, then increased feeding, weight gain plus slow height attainment, short stature, obesity, yes, hyperphagia, onset from 6 months to 6 years, mild to severe mental retardation, food related behavioral problem, binge eating, small hands, feet, puffy, small genitalia, hypothalamic pituitary dysfunction, growth, thyroid, adrenal, hypogonadotrophic hypogonadism. Natural history is decreased life expectancy due to morbid obesity. So they are having those behavior problems related to eating. Angelman is happy puppy syndrome. So this is like maternally derived severe MR paroxysm of inappropriate laughter. Yeah, this is happy puppy. Absent speech or less than 6 words, 100%, and most can communicate with sign language. Ataxia and jerky arm movement resembling a puppet's movement. This is 100%, and seizures most at age 4 may stop by age 10. So this is happy puppet syndrome. He is happy and then he has those jerky puppet-like movements, ataxia, and inappropriate laughter. This is 15Q, 11Q, 13. Facial features as the major defect. This is Robin sequence, pair Robin. This is mandibular hypoplasia. Okay, so we were also looking at the petau that was like mid-face thing, but this is mandibular hypoplasia in utero. Posteriorly placed tongue, posterior palatal shelves, cleft palate, other palatal abnormality, associated isolated finding or associated with some symptoms like fetal alcohol gas or adverse. Exactly. Oh, adverse. Findings are micrognathia and then retroglossia, possible airway obstruction because of the posteriorly placed tongue. Then we have this cleft, soft palate, and other abnormalities. Jaw growth over first years of life if it results from a deformation. If part of a malformation syndrome, then it is a fixed finding. Okay. Osteochondrodysplasias, um, achondroplasia, hypochondroplasia. Genetics are achondroplasia and have this is autosomal dominant and most common short limb dwarfism. 90% from new gene. Older paternal ages achondroplasia and hypochondroplasia, and this is autosomal dominant. And new gene, 90% new gene. Mutations in gene for fibroblast growth factor receptor 3 at 4p16, so FGFR. Findings are short stature, increased upper to lower segment ratio, short-limbed dwarfism. So this is the most common short-limbed dwarfism. Achondroplasia or hypochondroplasia. This is okay. Then we have short stature proximal femur shortening is pathognomic for achondroplasia. Megalocephaly, small foramen magnum may have hydrocephalus, small cranial base, prominent forehead. Okay, prominent forehead. Lumbar lordosis. Achondroplasia or hypochondroplasia, autosomal dominant. Normal intelligence, spinal cord compression is rare. Cervicomedullary junction usually occurs in first year of life. Tendency of late childhood opacity. Small eustachian tube, otitis media, hearing loss. Early cervical compression, respiratory problems, obstructive and central apnea. Later cardiovascular disease. Connective tissue disorder, Marfan syndrome. Genetics autosomal dominant with wide variability. Mutation in fibrillin gene FPN1 15q21.1. This is autosomal dominant. Marfan, early rapid growth of the appendicular skeleton, anterior ribs, major findings, tall stature, yes, with long, slim, little fat. Arm span is greater than height. Arachnodactyly, like a spider-like thing. Decrease upper to lower segment ratio as with XXY because the lower is not yeah. So we find this upper is to lower segment ratio in this and Klinefelter. Joint laxity with kyphoscoliosis, pectus excavatum, carinatum, lens subluxation, upward defect in suspensory ligament. Yes. and they are high miles. Ascending aortic dilatation with or without dissecting aneurysm, common in children and adolescents unless case is severe. It is uncommon, okay. With secondary aortic regurgitation, mitral valve disease, MVP and regurgitation is the most common in children. Okay, MVP and regurgitation in kids and ascending aortic dilatation with or without aneurysm. Yeah, who comes sort of picture. Then we have the natural history prevents scoliosis, vascular complications, chief cause of death, and evaluate heart and aorta. Ehlers loss is genetics. Type 1 most common, now 6 types. Autosomal dominant with wide variability. Findings are 2p ears, 2p ears, and then hyperextensible skin, fragile, easy bruisability, poor wound healing, joint hyperlaxity, tendency towards hip, shoulder, knee, and clavicular dislocations. Okay, we have this dislocation of the girdles, like big joints, and then MVP, tricuspid valve, aortic root dilatation, again like Marfan, dissecting aneurysm, ASD, blue sclera, wow. Blue sclera, myopia, glaucoma, ectopia lentis again, and retinal detachment and intracranial aneurysm. So how do you differentiate between them? Hyperextensible skin, I think, because we don't have this thing here. And also I didn't see any blue sclera here. And bruisability. Also, we can see bruisability in Marfan. Skin is very fragile. Okay. This is also autosomal dominant. Okay. So these all are autosomal dominant. Then we come to environmental agents. Etiology of FAST, fetal alcohol, severity of maternal alcohol use and extent and severity of pattern is more predictable ultimate prognosis. Alcohol, the most common teratogen to which fetus can be exposed. Findings are variable. Symmetric IUGR and postnatal growth deficiency, short stature. Mental retardation and microcephaly. Okay. This is pre, okay. So symmetric happens symmetric, okay. Fine motor dysfunction, irritability, infancy hyperactivity. Yeah, ADHD, yes. They have learning problem, behavioral problem. Mid-phase dysmorphism. Abnormal frontal lobe development. Okay, mid-phase problem. Frontal lobe. Short palpebral fissures, maxillary hypoplasia, short nose, short philtrum, thin and smooth. Yeah, this is very important. Smooth philtrum, short nose, thin and smooth upper lip. Like bow, like I think philtrum is like bow. Cupid's bow, something like that. Joint abnormalities, abnormal position or function, cardiac is VSD. Technology of palate is also associated with it. Okay. Fetal Hydantoin syndrome. Similar features with prenatal exposure to carbamazepine, valproate, primidone, and phenobarb. So everything is going to cause fetal Hydantoin syndrome. No dose-response relationship has been demonstrated. Growth deficiency, borderline to mild mental retardation, dysmorphic facial features. This is abnormal armor crease, rib abnormalities. Okay, Cupid's bow lips are in this fetal Hydantoin syndrome. Sorry. Yeah. So this is with all the anti-epileptics, whether it be carbamazepine or valproate or primidone or phenobarb. Okay, all of them are caused. Fetal valproate syndrome is different. Why? Because it has like cardiac defects, midphase hypoplasia, and meningomyelocele. Okay, meningomyelocele, midphase hypoplasia, and cardiac defects. Midphase hypoplasia was in fetal alcoholism. Yes, so Hydantoin is also like looks similar, but midphase hypoplasia. Okay, meningomyelocele is something that is fetal alcoholism. Okay, retinoic acid embryopathy from isotretinoin. All females who are to be treated with isotretinoin must take a pregnancy test, use definitive method of birth control, OCPs, and plus uh, condoms. Use one backup like condoms and receive counseling regarding teratogenicity. Mid-phase symmetry, mild facial asymmetry. Bilateral microtia. Yes. Ear abnormalities and renal. I know. Where is renal? Monotruncal. Okay. Sloping forehead, abnormal mottling of the teeth, facial nerve paralysis, ipsilateral to the ear, and decreased intelligence, thymic, parathyroid abnormalities. No problem if stopped before 15 postmenopausal days. This is very important. Before 15 postmenopausal days, then there are no problem. Pregnancy test required prior to the treatment initiation. So ear, facial nerve, phonotruncal, CNS, decreased intelligence. I don't know where I writing about female, but I think ear, phonotruncal, and facial nerve. That's it. Thymic, parathyroid abnormalities. Miscellaneous sequences, Potter sequence. Yes. Ultrasound is necessary for parents and siblings of patients with oligohydramnios, secondary to agenesis or dysgenesis of both kidneys. This is because 9% of first degree relatives have asymptomatic malformations. Okay. That's why we need to do it in oligohydramnios. Parents and siblings. Okay. The first degree. Etiology is renal agenesis or dysgenesis. Defect must occur prior to 31 days gestation. Oligohydramnios also from chronic leakage leads to fetal compression, mid-face and ears, lack of uh, alveolar sac development, pulmonary hypoplasia. Okay. Then findings are pulmonary hypoplasia, Potter facies, it is hypertelorism, apicanthal fold, low set flattened ears and micromnathia, and the compressed flatness. Crease presentation, abnormal positioning of hands and feet, deformations, limb abnormality, death from respiratory insufficiency. Okay? Because of pulmonary hypoplasia, they will die. So this is the problem. Main thing is renal agenesis or dysgenesis that causes oligohydramnios. Miscellaneous association, vectoral association, non-random association of we know this that this is imperforate anus is associated with vector. So V is for vertebral, A is for anal, imperforate anus, C cardiac defects, VSD and others, T is and E tracheoesophageal fistula, R is for renal and L is for lymph radial. Then we have the charge association which is associated with C is for coloboma of the iris and A is for choanal atresia. So this is charge. Coloboma iris associated isolated iris to anophthalmos retinal most common. Heart defects, TOF, PDA, others, atresia coini, retardation of growth and development, genital hypoplasia in males. This is G is for genitourinary in males and E is for ear abnormalities, like auricular tags and pits and those things. Charge association. Then we go down and we see the growth and nutrition. Childhood growth. So newborn typically loses up to 10% in the first week of life. We know this should regain or surpass the birth weight by 2 weeks. Okay, 30 grams per day in the first month of life. It slows to about 20 at 3 to 4 months. Typically doubles birth weight by 6 months, triples by 1 year. Slows further between 6 and 12 when then appetite begins to decline through 18 months of age. Height and weight increase at a steady state. But head circumference rate of growth decreases somewhat 2 to 5 years. Between age 6 and 12 years, 3 to 6 growth spurts each year for 8-week periods each. Slower brain growth, myelination complete by age 7. That's why we say that it is like by 5 years, 90% of the brain development has occurred. Between age 10 and 20, acceleration in early adolescence. Boys, highest growth stops at age 18. Their average peak is 13.5. Girls' average peak is 11.5. That's 2 years less. And stops at age 16. They are 2 years less. Okay. 11.5 and 13.5. Okay. Assessment of growth. Child is genetically programmed to stay on 1 to 2 growth curves after age 2 years. Height percentile at age 2 years correlates with final adult height percentile. Low birth, okay, at 2 years, okay, and then low birth weight and very low birth weight may continue to show catch-up growth to early school age. Weight height less than 5th percentile is the single best. Yeah. For acute, in nutrition insufficiency, weight decreases before length, so weight height is low. For cause of decreased linear growth, length decreases first or at the same time as weight growth hormone. BMI is accepted as best clinical indicator for under and over. For bone age reference standards, use radiographs of left hand and wrist. Skeletal maturity is linked more to cerebral maturity than chronologic growth pattern. Growth chart is the best tool to determine patterns of growth. There are separate growth charts for both boys and girls. Chart measure weight for height. Yeah, I know this. Then each chart has multiple curves, either 5 to 95% or 3 to 95%. Evaluation of the growth. Growth velocity is slope, the change in height and change in age. This is growth velocity. Then chronologic age is actual age. Bone age is the X-ray of left hand and wrist of the non-dominant hand. Okay. Bone age is equals to chronologic age. This means that this is ideal or can be genetic, familial, short stature. Abnormal can be genetic and chromosomal. Bone age is less than chronologic age. This is in constitutional delay. And chronic systemic disease, endocrine, systemic or endocrine disease, chronic. Okay. Then we have bone age, which is greater than or up to chronologic age. This can be obesity, tall, or familial tall stature. Abnormal can be precocious puberty, catch syndrome, and then this congenital adrenal hyperplasia (CAH), and then hyperthyroidism. Okay, we have shown these graphs. Okay, so this is constitutional delay. Bone age is less than the chronological age. This is constitutional delay. So this person is constantly on the lower, the most lowest line, following the most lowest that milestone line, and then he does a catch-up growth after that, and he just comes on to between 50 and 25. And this one, there should be another one. Bone age is less than chronological age in growth hormone deficiency. Okay, so this person is very low on the line, and then he just does a small catch up. I think when they supplement him with growth hormone or something. Or, yeah, but it's still between 25th and 10th. Yeah, near the 10th percentile. Okay, they did the growth hormone replacement here. Okay, so he did the catch up growth. Great. Then this is familial short stature. So bone age is equal to the chronologic age. Yeah, so this person is like short stature. He is like following the line. If there's no jump or jumping, yeah, going down. Okay, and then disorders of growth. Okay, so I'll just have a look at the chart again, the table again. Yes, so this was bone age equals to chronological age, which was genetic and chromosomal if it was a problem. Bone age bone age less than constitutional disease, less than chronological age, and then chronic systemic disease and endocrine related. Okay, growth hormone related. Okay, here it is. Greater than was tall stature and obesity, but it was due to precocious puberty, catch and hyperthyroidism. Okay, so disorders of growth now. This is short stature. Height. Suspect Turner with pathologic short stature. Craniopharyngioma if short stature and visual problem. Okay, that's great. Short stature plus breathing formula equals to craniopharyngioma. If just short stature, then can be termination in females. Short stature, father is worried that his 13-year-old son is short. Child has been very healthy. He is below the 5th percentile for height and has been all his life. Father is 6'3", mother is 5'10". Father was a late bloomer. Constitutional growth delay. Child is short prior to the onset of delayed adolescent growth spurt. Parents of normal height, normal final adult height is reached, growth spurt and puberty are delayed. Bone age is delayed compared to chronological age. This is constitutional. Then we have the familiar. Parallel to the growth curve, strong family history of short stature, chronologic age equals bone age, and pathologic is starts out in normal, then start crossing growth percentile. Can mean craniopharyngioma, hypothyroidism, hypopituitarism, nutritional problem, other chronic illnesses. Craniopharyngioma with vision problem, short stature with vision problem. Tall stature, usually a normal variant, familial tall stature. Other causes are exogenous obesity, endocrine causes, growth hormone excess, gigantism, and acromegaly. Androgen excess, yeah, and syndrome are homocystinuria, SOTOS, and okay, homocystinuria also is tall. SOTOS and Klinefelter, but homocystinuria and SOTOS, like they are tall stages. Can be because of catch. I don't know. Yeah, we were telling that bone age was greater than the chronological age, and that was because of catch, because of puberty, hyperthyroidism. Okay. Weight, organic failure to thrive. A baby weighs 16 pounds at 1 year of age. Birth weight was 8 pounds. Parents state that the baby feeds well. Physical exam reveals the baby with little subcutaneous fat, long, dirty fingernails, fatigue, and a flat occiput is neglect. Malnutrition, malabsorption, infection, celiac, cystic fibrosis, disaccharide deficiency, protein-using enteropathy, allergies, immunodeficiency, chronic disease. Initial diagnostic test is first thing is to document the caloric intake. Then CBC, urine analysis, LFTs, and renal function test, and serum protein, sweat chloride, stool for ovoparasite, everything. This is a patient who has kwashiorkor. Note generalized edema secondary to low serum albumin. Okay, because of protein. This is specifically the protein problem. That's why there is non-organic failure to thrive in a 4-month-old infant presents to the emergency because of upper respiratory symptoms. Patient is less than 5 percentile in weight and length. He is 3.5 kg. Birth weight was 4.2 kg. Mother states that the patient takes 16 ounces of infant formula per day with cereal added. Child is usually infant, not fed adequate calories. Emotional or maternal deprivation concurrent with nutritional deprivation leads to neglect. I don't understand why they didn't say that this one was not neglect, because this person also has this fat, long, dirty fingernails. This was impetigo because they were not caring for this. I don't know why they are saying that was organic failure to thrive and this is non-organic. Okay. Retarded or emotionally disturbed parents and poverty. Then thin extremities, narrow face, prominent ribs, wasted buttocks, neglect of hygiene. So flat occiput and hair loss may indicate excessive backline. Okay, excellent. So the previous one also had this one, that he was also neglected. Delays in social and speech development. Avoidance of eye care. Expressionless, no cuddling response. Feeding aversions. Diagnosis is feed under supervision, may need hospitalization for 1 week. Should gain greater than 2 ounces per 24 hours over the week. May have a ravenous appetite. Careful observation of mother, may need videotaping. Then delay extensive lab evaluations until after dietary management has been attempted for 1 week and has failed. Management is all cases caused by underfeeding from maternal neglect must be reported to CPS. Yes, must be reported to CPS, Child Protective Services. And then we have the infant discharge to natural home require intensive and long-term intervention. Feed as above usually require greater calories for catch-up growth. May need NG feedings or even gastro-stomach in severe cases. Obesity, risk factor predisposition, parental obesity, family patient inactivity, feeding baby as a response to any crying, and rarely associated in syndrome like Prader-Willi and Down syndrome. Presentation is a short, tall stature in some, abdominal is dry. Associated obesity of extremities, increased adipose tissue, memory tissue, involves large pubic fat pad, early puberty. BMI is greater than 95% for age and sex is diagnostic for obesity. 85 to 95 is overweight, but more than 95 is obesity. Diagnostic of obesity. Okay. 85 to 95 is writing, this is overweight. Then we have complication. Obese infant and children are increased risk of becoming obese adult. Risk is greater with advanced age of onset. Cardiovascular hypertension, increased cholesterol, hyperinsulinism, slipped capital femoral epistasis. Yes, this SCFE always occurs in an obese child. Sleep apnea, type 2 diabetes, acanthosis nigricans, metabolic syndrome. Treatment is exercise, balanced diet, and no medication. That's it. Feeding. Normal newborn has sufficient stores of iron to meet requirements for 4 to 6 months, but iron store and absorption are variable. Breast milk has less iron than most formulas but has higher bioavailability. You know this formula is supplemented with vitamin D. Breastfed must be supplemental from birth, 400 IU per day. Okay, yeah, breastfed, yeah. Vitamin K routinely is given IM at birth, so supplementation is not needed. Breast milk and formula are 90% water, so no additional water is needed. Breastfeeding. Mothers with HPV infection are free to breastfeed their infants after the newborn has received the appropriate recommendation vaccinations against HPV. A nursing mother asks if her 3-month-old baby requires any vitamin supplementation. Most infants can breastfeed immediately after birth and all can feed by 4 to 6 months. The feeding schedule should be self-regulation, most established by one month. Advantage psychological, emotional, maternal, infant bonding, pre-mixed, right temperature, concentration. It's cheap. It has immunity, protective effects against enteric, other pathogens, less diarrhea, intestinal bleeding, spitting up, early unexplained infant crying, atopic dermatitis, allergy, chronic illnesses later in life, passive transfer of T-cell immunity, decreased allergies, maternal weight loss, faster return to preconceptional the uterine size. Contraindications of this thing is, I think the only contraindication is that maternal HIV in developed countries. CMV, HSV, if lesions on the breast, so we treat them and then I think the mother can breastfeed. HBV, yeah, if the infant is immunized, no problem in feeding. Then acute maternal disease, if infant does not have disease, it's like TB and sepsis, and we don't. And breast cancer, like mother is also like is undergoing some chemotherapy. Substance abuse, yes, alcohol, it's the same as in blood. The levels are the same in the breast milk. Drugs, absolute contraindications are antineoplastics, radiopharmaceutical, ergot, alkaloids, iodide, mercury, yes, radioiodine when the person is taking radioiodide for this thyroid therapy. We don't give atropine, lithium, chloramphenicol, cyclosporine, nicotine, alcohol. Relative are neuroleptics, sedatives, tranquilizers, metronidazole, tetracycline, steroids. Breastfeeding is not contraindicated in mastitis. I would like to know this like lithium, chloramphenicol, atropine, antineoplastic like cancer, radio, even iodide, mercurial, don't. Then we have this thing called Component: human milk and cow milk. Comparison of breast milk to cow milk. Same, and the water is same. Calories is same. Protein, like whey dominant. This is whey dominant. That is casein dominant. Cow is C is for cow and C is for casein. So casein dominant. And then the fat is high and low chain, and that one is medium chain. So yeah, it's much more easy to digest because human milk has low chain. Iron is better absorbed, low iron in copper. Then diet dependent, low in potassium. Low in potassium. Okay, low in vitamin K. I think. Low in C and D. Okay. Then digestibility is faster and emptying. Same after 45 days. Renal solute load. This is very important. Low. So it aids in renal function. This is higher. So yeah, not good. Okay. Formula feeding. Do not give cow milk to infants aged less than 1. Infant formulas. Formula feeding is used to substitute or supplement breast milk. Most commercial formulas are cow milk based with modification to approximate breast milk. They contain 20 calories per ounce. Specialty formulas, soy, lactose-free, premature, and elemental are modified to meet specific needs. Formula versus cow milk or Fe deficiency anemia with early introduction less than 1 year of a cow's milk. And advanced feeding is stepwise addition of foods, one new food every 3 to 4 days. Okay. Solids, iron fortified cereal only at 4 to 6 months, stepwise introduction, vegetable, fruit, then dairy meats, then table food at 9 to 12 months. Food better safe for 2 years. Year 2 are egg whites and nuts and honey and chocolate and citrus and wheat products and fish. Really? For year 2. Okay. They're not even giving egg whites. Chocolate I will not give at any point. Nuts, okay. Wheat and fish. No honey in first year of life because causes infant botulism. Now we are on development. So developmental delay is just performance is significantly below average. Yeah. So developmental age divided by chronological age multiplied by 100 of less than 75. One or more areas, two assessments over time are more predictive than a single assessment. We know this thing. So if we have one area that is that has abnormal development, then we need to do a careful assessment of all the stuff. This is important. Major mental retardation IQ less than 70 to 75 plus related limitation in at least two adaptive skills like self-care, home living, work, communication, then we call it mental retardation. Communication disorders, deficit of comprehension, interpretation, production, or use of language. Learning disabilities, one or more of defined by federal government based on standardized tests. Reading, listening, speaking, writing, and math. Cerebral palsy, attention deficit, ADHD, autism spectrum. These are okay. Medical evaluation and Denver 2 developmental assessment. Suggested at every well child care visit. Allows generalists to identify possible delay. Need further evaluation for definitive diagnosis. For infants born less than 38 weeks, correct just age for prematurity for up to 2 years. Yeah. We do this, but for developmental milestone, but not failure is at least 2 delays. This is also important, yeah. But not for the vaccination. We don't correct the age of prematurity. Primitive reflexes and developmental milestones. An infant can sit up with its back straight, has started crawling, has a pincer grab, and plays a peekaboo. What age is appropriate for this baby? Okay, he's started crawling, has a pincer grip. Probably this is 9 months. Okay, appear and disappear in sequence during specific period of development. Appear absence or persistence below beyond a given time frame signifies change. So exam question typically describe an infant and ask for the corresponding age. Moro is extend head extension fraction of the arms and legs. Appears at birth 4 to 6 months, disappears. Brainstem vestibular nuclear. Crest feels like you give anything, finger in palm and heel grasp. Hand, elbow, shoulder flexion. And birth and then brainstem vestibular nuclear. Rooting, cheek stimulus turns mouth to dead side, birth 4 to 6 months, brainstem. Trigeminal system. Okay. Then we have rooting, then we have trunk incurvation. So withdrawal from stroking along the ventral surface. Okay, on the ventral surface we stroke and then we see withdrawal and then this is birth and spinal cord. 6 to 9 months, trunk incurvation. Placing is steps up when dorsum of the foot is stimulated. This is also disappears by 4 to 6 months. This is cerebral cortex. Asymmetric tonic neck disappears at 4 to everything disappears 4 to 6 except for parachute. Simulate for and the person is just extending their arms. This comes late 6 to 8 months and disappears then. Penis stem vestibular. Then so at 6 to 8 months I think we just have this parachute reflex. Yes, we can also have this trunk incurvation depending on like if it disappears early 6 months then we don't have. But yeah, other than that we don't have any other reflex. Then we have the cross motor, then fine motor, then language and social. Okay. So birth regards face, alerts to sound, visually fixes on an object, symmetric movements in spine and head flat in prone. Prone position does not lift the head. 2 months, head is in midline while held sitting, raises head in prone, begins to lift chest, and it also develops a social smile, recognizes parents and follows past midline. If we follow the finger, then he will. Yeah. Visual motor is follows past midline. Then we have 4 months. He holds the head steadily. Yeah. Now this neck support is here. Supports on forearm in prone. Rolls from prone to supine. Reaches with both arms together and hands to midline. Laughs and orients to voice and coos in 4 months and likes to look around. 6 months. Sits with support, even can sit without support, feet and mouth in supine. Oh yes. Unilateral reach, raking gasp is raking. Gasp is very important. It can determine which age it is and transfers objects from one hand to the other. And this 6 month babbles and recognizes that someone is a stranger. Yes, now the stranger anxiety is real. 7 months, roll from supine to prone. It was prone to supine at 4 months, and now this is supine to prone. May crawl, starts to sit without support. 9 months crawls well, pulls to stand, starting to cruise. And 9 months they have a pincer grip. This is immature. Holds the bottle, throws the object, not overhand. Overhand, I think it will be 1 year. Mama, Dada indiscriminately understands no, understands gestures, who plays gesture games, explores environment, crawling, cruising. This is 9 months. Then 12 months is may walk alone, bust by 18 months. Mature, princegraphs, crayon marks, object permanence. Then 1 to 2 words other than mama and dada and used appropriately follows one step command with gesture. Imitates actions, comes when called, and cooperates with dressing. 15 months is creep upstairs, walk backward, scribbles, build tower of 2 blocks. 2 blocks is 2 or 3 blocks is 18 months. Tower of I think okay 3 blocks is 18 months. 4 to 6 words. He has a vocabulary. 15 months he has a big vocabulary. Uses cup and spoon. 18 months has knows 5 body parts. Imitate parents in task, plays in company of other children. They are saying 18 months can throw objects overhand while standing. Then 24 months is parallel play. Like they will play with all the other kids are playing and they will be also playing, but not group play. Group play will come at 3 years. 50 words and they can 2 word sentences, follow 2-step command, use pronounce inappropriately. Yes, he or she always mixed up. Imitate a stroke up or down. Imitate a stroke up or down with pencil. Yes, can I think mm, make a line. Removes clothing, builds tower of 7 blocks, walks up and downstairs 1 foot at a time. 3 years is alternate feet. Pedals tricycle is 3 years. Okay, copies a circle is 3 years. Undresses completely, dresses partially, unbuttons, dries hand. Greater than 250 word vocabulary, 3 word sentences, plurals, pronouns, group play shares, takes turns, knows full name, age and gender. 4 years. Alternate feet, going downstairs, hop and skips. Copies are square, button clothing. So this is square thing, is 4 years. Catches ball, knows color, recites song from memory and colors, okay. 4 years is colors. Plays cooperatively, tells tall tales. Okay. Skips alternating feet, skipping come at 5 years, jumps over lower obstacles, copies triangle, ties shoes, spreads with knife, prints first name, asks what a word means, answer all WH questions. Tell a story, plays pretend, knows alphabet, okay. Plays cooperative games, abide by rules, likes to help in household tasks. So this is a cooperative thing, comes at 4 years. Okay. Possible abnormalities. You must take into account for the number of weeks of prematurity to assess development appropriately. That is for the preterm age, not chronological. For instance, a 6-month-old baby born at 32 weeks, that is 2 months preterm, must be assessed at 6 minus 2, 4 months to activate. Okay, and we are doing this till 2 years of age, chronologically. If there is a language delay, then first consider conductive hearing loss. While all babies receive hearing testing, that is for congenital sensory neural. Over the first week, conductive may occur from repeated hearing function. There is a lack of development or regression, which impairs social interaction, restricted activities, and interest and stereotypic behaviors. Consider autism. After a complete history physical with neurologic and development testing, first step is to perform an autism screening questionnaire. If you feel the diagnosis is likely, the next step is to refer to a specialist in this area. Delay is defined as greater than or up to 1 skills significantly below average, that is developmental quotient. Developmental age, okay. And when you find this, you must look for a possible reason. The child will need developmental therapy in greater than 1 areas, greater than or up to 1 area. Behavioral psychological disorder. Eating disorder. PICA. Repeated or chronic ingestion of non-nutritive substances, example, paint and dirt, after year 2 needs investigation. Predisposing factor, mental retardation, lack of parental nurturing, also with family disorganization, poor supervision, psychological neglect. More common with autism, brain behavior, and low socioeconomic status. Keys just for lead poisoning, iron deficiency, parasitic infections. Elimination disorders and USA. A 7-year-old boy has Problems with bed wetting. Mother says that during the day he has no problem, but is usually wet 6 or 7 morning. He does not report dysuria or frequency and has not had increased thirst. Mother also says that he is a deep sleeper and he's 7 years old. Definition is voluntary or involuntary repeated discharge of urine after a developmental age when bladder control should be present, most by age of 5 years. There are two types primarily. There is no significant dry period and it's usually nocturnal. Hyposecretion of ADH and or receptor dysfunction can be the cause. Relationship of sleep architecture, diminished arousability during sleep and abnormal bladder function. Anatomic malformation. Management is thorough history and physical should begin with behavioral treatment, not definitive, varying success rate. Endless cooperation of the child. So chart dryness, reward system. Child should void before going to sleep, okay, and alarm to wake once 2 to 3 hours after falling asleep. May use alarm that goes off when child wets a special heat. Wet and bell and pet alarm. No punishment or humiliation. Psychotherapy for traumatized children or when behavioral therapy has failed. Pharmacotherapy for failed behavioral therapy in nocturnal aneurysms, oral desmopressin. Secondary. After a period of dryness greater than or up to 6 months, uh, causes are psychological, UTI, constipation, diabetes. Okay, so we need to just check these causes. More common in girls, evaluation is urine analysis. Management is feed and underlying disorders. Children with both diurnal and nocturnal, especially with voiding difficulties, more likely to have abnormalities of the UTI, maybe some fistula or something. So then we need ultrasonography or flow studies are indicated in these cases. Now, encopresis, the passage of feces into inappropriate places after a chronologic age of 4 years. Okay. After 4 years, if there is fecal infection, fecal incontinence sort of thing, then this is encopresis. Maybe primary or secondary. Causes are psychological. Toilet phobia, early toilet training, aggressive management of constipation, painful defecation, fissures, anything can cause encopresis. Retentive is most common. Two-thirds of the cases, hard stool on rectal exam is sufficient to document, but a negative exam requires a plain X-ray. Presence of fecal retention is evidence of chronic constipation. Thus, treatment will require active constipation management. May have abnormal anal sphincter function. Associations are primary encopresis, especially in boys associated with global developmental delays and aneurysm. Secondary is high level of psychosocial stresses and conduct disorder. Okay. Management is first clear the impacted fecal material and short-term use of mineral oil or laxative. No long-term laxative use. And concomitant behavioral management. Regular postprandial toilet sitting. High fiber. Familial support for behavior modification. Group or individual psychotherapy. Must be clear and short-term use of mineral oil or laxative. Very short-term. No long-term laxative use. And then behavioral. So, regular postprandial toilet sitting, high fiber diet, familial support, and group or individual psychotherapy. So, most of it was retentive. Then we have sleep disorders, parasomnia. Definition: episodic nocturnal behavior that often involve cognitive disorientation and autonomic and skeletal muscle disturbance, as associated with relative CNS maturity and more common in children than adults and obesity. So they are either sleepwalking and sleep terrors or nightmares. So sleepwalking and sleep terrors they are occurring in the first part of the night, first third of the night, and during the slow wave sleep. And there is no daytime sleepiness or recall. There's no recall. That is very important differentiating factor. And high arousal threshold, like agitated if awakened. Family history is common, and then the sleepwalking is relatively common. Night terrors are rare. Sleepwalking is very common. Okay. Then treatment is just parental education, reassurance, and avoiding the exacerbating factors, that is sleep deprivation, safety precautions. Nightmares laster and they occur during the REM sleep, and there is daytime sleepiness and a vivid recall. Low arousal threshold, so easily awakened, and there's no family history and maybe displaced from bed, very common, and not no required treatment unless persistent treatment, in which cases possible abuse or anxiety disorders should be investigated. Okay. Then we have the next step, immunization. Now the immunizations chapter, learning objectives, and then a 6-month-old patient is being seen for routine care. Baby is doing well, physical exam, growth, development, everything is normal. Mother states that after the last set of immunization, baby had a temperature of 39.4, that is 103, and cried for 2 hours but was consolable. What is your advice to this mother before administering the next set of immunization? So, active immunizations. Um, Viral, bacterial, we know this all thing. So, vaccine route. For stimulation of an adequate and persisting antibody response, 2 or more doses are usually required. Interchangeability of vaccine products in general, most vaccine from different manufacturers may be interchangeable. Simultaneous administration can be safely and effectively given simultaneously. Lapsed immunization. A lapse in schedule does not require reinstitution of the entire series. Unknown or uncertain, when in doubt, the child should be considered to be disease susceptible and appropriate immunization should be initiated without delay. To be counted, the vaccine must be documented on a formal immunization record regardless of the country. Okay, so this is important. Dose, no reduced dose or divided dose should be administered, including to babies born prematurely or at low birth. Exception is first dose hepatitis B. Okay, so this one can be like dose reduced or divided dose, something like that. Then we have the active immunization of people who recently received gamma globulin. Live virus may diminished immunogenicity when given shortly before or during the several months after receipt of immunoglobulin. So live vaccine is delayed 3 to 11 months. Okay, either we give right away with them or give like 3 to 11 months delay. Okay, Institute of Medicine Immunization Safety Review Committee findings does not support the hypothesis that MMR causes any autism associated disorder or inflammatory bowel disease. Okay, and then based on epidemiologic evidence, there is no causal relationship between multiple immunization and increased risk of immune dysfunction and type 1 diabetes. There's nothing, no causal relationship between hepatitis B and demyelinating neurologic disorders. No causal relationship between meningococcal vaccine and Guillain-Barré. Preservative thimerosal, uh, mercury containing no causative or any problem has now been removed, although it's not used now, but it's also not causative of any problem and also it has been removed. Misconception: the following are not contraindication to immunization. Reaction to a previous DTaP of a temperature of less than 105. Less than 105 is okay. Okay, not contraindications. These are not contraindications. Redness, soreness, swelling, mild acute illness in an otherwise well child, concurrent antimicrobial therapy, prematurity, immunology, chronologic age, family history of seizures, family history of sudden infant death. There's nothing. Then we have accepted precautions and contraindications. Minor illness with or without a fever does not contraindicate immunization. Fever per se is not a contraindication. Guidelines for administration are based on physician's assessment of illness and on specific vaccine the child is scheduled to receive. If fever or other problems such as moderate or serious illness, the child should not be immunized until recovered. Okay. Documented egg allergy is not a contraindication to MMR. MMR is derived from chick embryo fibroblast tissue culture but does not contain a significant amount of egg cross-reacting protein. So MMR is not from the, okay, so it does not contain. Okay, influenza does contain, and on rare occasions may induce a significant immediate hypersensitivity reaction. Acute immunization after the disease exposure. Measles, age 0 to 6 months. Immune serum globulin if mother is not immune. Otherwise, or pregnant or immunocompromised, then IgG. All others, vaccine within 72 hours of exposure for susceptible individual. Okay, within 72 hours is okay. Varicella, give varicella to susceptible immunocompetent contacts ages greater than 12 months as soon as possible, and these are IG to all immunocompromised susceptible pregnant women. No vaccine or PCIG for healthy infants aged 0 to 12 months. Okay. Without IG also for susceptible pregnant women, newborn whose mother had the onset of chickenpox within 5 days before delivery to 48 days is important. 5 days to within 5 days to 48 hours after. And certain hospitalized premature infants, they need to get PZ-IG. Otherwise, we don't give PZ-IG. Vaccine to everyone who is immunocompromised. And VZIG to all immunocompromised infants. They are saying no vaccine or VZIG. This is not making very good sense to me. Then hepatitis. Hepatitis B after exposure in non-immune patient, give hepatitis B IG plus vaccine, repeat vaccine in 1 and 6 months. Okay. Hepatitis A, if patient is not vaccinated, then give dose of vaccine as soon as possible, but within 2 weeks of exposure. Okay. Within 2 weeks of exposure, we have to give for hepatitis A, hepatitis B. We are giving repeat vaccine in 1 and 6 months. Mumps and rubella, not protected by post-exposure to not protected. There's nothing we can do. Recommended for exposed adults who are born in US in or since 1957 who had not previously or had or been immunized against either except pregnancy. Okay. And this is done. Specific vaccine and routine vaccination. Hepatitis B first dose soon after birth before hospital discharge with a total of 3 doses by age 18 months if the mother is HBsAg negative. If the mother is okay negative, then we give these two. The infant born to a hepatitis B surface antigen positive mother should receive the first dose. The infant born to a hepatitis B surface antigen positive mother should receive the first dose of hepatitis B virus plus hepatitis B IG at 2 different sites within 12 hours of birth. All 3 doses should be given by age 6 months. Treat same as exposure. Okay. So this one was by age 18 months and this is by age 6 months. Okay, this is the difference. This is the big difference that if it is hepatitis B surface antigen negative, then we are giving soon after birth and we are just giving the vaccine. 3 doses by age 18 months. And this one who has like a positive mother, hepatitis B surface antigen positive mother, then we are also giving 3 doses but by age 6 months and we are also giving the IgG. So treat as same as exposure. All children and adolescents who have not been immunized and should begin the series during any visit to the physician. Then we have DTaP. All DTaP vaccine for US currently contain acellular pertussis. Rates of local reaction fever are substantially lower with acellular than with whole vaccine. Use DT, there has been a serious reaction and also for any catch-up after age 7. No full dose pertussis after age 7. Okay. This is important. Total of 5 doses of so they are using GT if there is a serious reaction. Total of 5 doses recommended before school entry with the final at preschool age 4 to 6 years. Pertussis booster T that is now recommended during adolescence regardless of immunization status. Also recommended even if one has already had pertussis. Okay. Recommended even if the person already had pertussis is recommended during adolescence. Okay. And Tdap, childhood tetanus. Tdap or that was okay is given age 11 to 12 and then TD Every 10 years. Okay, they are giving every 10 years. Okay. And we have tetanus, history of doses of tetanus toxoid, less than 3 or unknown. Yes, and they start, and then TD is yes, and TIG yes. And if it is less than 3, then no, unless we greater than 10 years from the last dose. And we don't give immunoglobulin, no, unless greater than 5 years from the last dose. This is no. Yeah. Less than 3 or unknown, then we are giving TD and yeah, or clean minor wound. And all others, then we are giving TD and TIG. Yeah. This is different in UK. IPV inactivated is now the only polio vaccine available in US. 4 doses of IPV with the last at the 4 to 6 years. Any child up to 18 years of age should receive all doses if behind. Okay, we can use it if 18 years of age. Any child who has received OPV from other countries should receive schedule in US with. Okay, if you have received OPV, then you have to complete a schedule in US with IPV. H. Haemophilus influenza B conjugated vaccine does not cover non-typable. Depending on the vaccine vendor, recommended primary series consists of 3 or 4 doses after primary series with 12 to 15-month booster. If immunization is not initiated until age 15 to 69 months, this means I think 5 years. Then there's a catch-up, 1 dose, but not given after 5 years of age in normal children. Invasive disease does not confirm immunity. Patients still require vaccines if age appropriate, that is, age less than 5 years. Pneumococcal vaccine. Pneumococcal conjugate vaccine PCV13. Okay, and this is a purified polysaccharide of 13 serotypes conjugated to diphtheria protein. Okay, it is conjugated to diphtheria protein. No. Routine administration is a 4-dose series for all children aged 15 months and younger. If no dose given, 15 months and younger. Okay, PCV 13, young patient, less than 15 months, so PCV 13, lesser number. 20 valent, if no dose given yet, then there are catch up. 23 valent, PS, this is polysaccharide, PS 23 and PCV 13. PCV is 13 and PS 23. PS 23 is given an additional protection to the PCV 13 in some high risk, only in some high risk children, example functional or anatomic asthenia, age greater than 2 years. Then we give functional and anatomic asthenia. Then we give PS 23 in high risk children. Varicella recommended at age 12 months or older for healthy people who have not had varicella illness with second dose at age 4 to 6 years. Catch up dosing. Okay, and then varicella is like, okay, just leave it. Most people age greater than 18 immune without a reliable history of varicella will still be immune. Okay. MMR is live attenuated. First dose at age 12 to 15. Second dose at preschool. Catch up 2 doses. Then Hep A is 12 to 23 months. 2 doses apart. Less than 1 year. This is less than 1 year. 12 to 23 months. We can give 2 doses. 6 months apart. Hepatitis A. For chronic liver disease, yes. Homosexual, bisexual man, users of illegal drugs, patients with clotting factor disorders, and those at risk of occupational exposure can give with other vaccines. Okay, so chronic liver disease patient and meningococcal and conjugate vaccine, MCV4. MPSV4 is the older pure, while MCV is conjugate, newer. MCV4. Okay, give it newer conjugated. Then administer MCV to all children of the age 11 to 12 with it, and then booster at age 16. All college freshmen Okay, and there's now a vaccine for serotype B used for high risk patients and during outbreaks. Status post concurrent type B outbreaks at Princeton and UC Santa Barbara. Influenza vaccine. Inactivated influenza vaccine, typical flu shot, administered IM. Egg allergy. It has been found that most patients with no documented severe allergy to eggs can safely receive. Appropriate caution should be taken and they should be watched in a medical setting for at least 30 minutes. Give annually during flu season for children greater than 6 months. A strain, B strain, and H1N1. Live influenza is administered intranasally and it is contraindicated in immunocompromised given only to healthy people 2 to 49 years of age. Not pregnant, do not have certain health conditions. Rotavirus, oral live attenuated vaccine given at ages 2, 4, and 6 months. Essentially, no catch up is behind. So, no dose after age 8 months. So, we don't do the no catch up. Okay, 2, 4, and 6 months rotavirus vaccine. And safe, highly effective, no interception, M&M from disease, reduced significantly. Okay. Yeah, we have to remember this rotavirus interception, but no interception. M&M from disease reduced. What is M&M? HPV, quadrivalent vaccine or bivalent at the 11 to 12 years visit through age 26. For cervical cancer prevention, quadrivalent to boys. Okay, we can give bivalent to girls also. Okay, and quadrivalent and bivalent. Anything to girls, 11 to 12 through age 26, and for boys, it's just age 11 to 12 years. For genital warts caused by HPV 611, can give in both males and females as early as age 9. It's okay. Then we have 3 doses now, 9 valent in both girls, 9 to 26, boys 9 to 15, 611 for genital, yeah, 16, 18 is for the high risk one, 16, 18, 31, 33, 45, 42, so this is 9 valent in both girls and boys. Precancerous lesion, all 9 including anal, intraepithelial neoplasia, anal cancer. Doses 2 and 3 give at 2 months and then 6 months after birth. This is the CBC chart. Child abuse and neglect, the next chapter. Okay. Quick go through of this chapter, child abuse and neglect, and it's just very there's another by law in all 50 states. Yeah, I'm just doing it a very uh, easy way. Child maltreatment, physical abuse, psychological neglect, and all that spurning and all that stuff. Sexual abuse, factitious disorder, failure to thrive, developmental delay, learning ability, physical disability, something like that. Epidemiology, caregivers have a history of abuse by young parents and lower socioeconomic, closely spaced pregnancy, military bases, spousal abuse, substance, single parent, teenagers, even mentally retarded children, high level stress, and preterm low birth weight infants. Physical abuse. Certainty is not required to file report to CPS. However, one must determine whether parents have an understanding of disease process and intellectual, emotional, economic, and physical resources to provide for the child. 2-year-old child presents boy presents to emergency with skull fracture at the mother's table. The child acquired after falling from a sofa onto a carpeted floor. During physical exam, child is alert. He is noted to have old bruising on her buttocks and back, as well as cigarette burn on his palm. Mother states that the child falls a lot and is always touching things he should not. So when the injury is unexplainable or implausible, incompatible with the history given or the child's level of development, there are no reports of death or serious brain injury from witnessed fall less than 10 feet. No, I know this. No reports of, yeah, if this is less than 10 feet, then no reports of death or serious brain injury. Better child syndrome is but bruises, scars, turnover organ damage, fractures in various stages of healing. Then bruises in various stages are not compatible with a single event. This is very important. Staging is important. Cultural issues, example, coining and cupping. So, then we have fractures. Differential diagnosis when with osteogenesis imperfecta or severe osteomalacia, there is an increased incidence of pathologic fractures, but they are rarely of the metaphysis. This is very important. That metaphyseal fractures, they will rule out these things. Osteogenesis imperfecta and osteomalacia. Wrenching or pulling an extremity, corner, chip, or buckle handle fracture of the metaphysis. Okay, so metaphysis is like corner, chip, or buckle handle fracture. Wrenching and pulling. Inflicted fracture of the bone shaft most likely spiral from twisting rather than transverse from the impact. This is twisting and spiral and inflicted fracture of the bone shaft. Okay, a spiral fracture of the femur before child can walk independently has usually been inflicted by someone else. Yes, this is very important. Accidental impact rarely causes rib fracture or retinal hemorrhages in children. Then highly specific for abuse is rib fractures in infant. Fractures of different stages of healing, bilateral fractures, complex skull fractures, burns. Cigarette burns, circular punched out lesions of uniform size, immersion burns, most common in infant, glove stocking pattern, dipping into bathtub. So this is demarcation is uniform, distinct, and flexion creases are spared. No splash burns. Hands and feet are spared and incompatible with falling into tub or turning a hot water while in tub. Yes. So first the feet will burn or hand will burn. So this is incompatible. Like someone is just putting the child in the hot water. Yeah. And then intentional head trauma, most common cause of death considered when injured infant present with coma, conversion, apnea, increased ICP. Subdural hemorrhage occurs because there are no scalp marks or skull fracture. Trauma, hand blow. Retinal hemorrhage, shaking, acceleration, deceleration may have no sternal mark. 85% associated with retinal hemorrhage. Intra-abdominal injury. Always obtain a CT scan for intracranial bleeding and an eye exam for retinal hemorrhage impacts. Recurrent vomiting. If stuck with fist, then row of 3 to 4 teardrop shaped 1 centimeter bruise in a slight cuff. This is fist. May rupture spleen, liver, laceration of small intestine at sites of ligamental support. Intramural hematoma and temporary obstruction. Free air. Okay. And then we have lab studies. Skeletal survey when you suspect abuse in child aged less than 2 years. In child greater than 2 years, appropriate film area of injury. Complete survey is not usually required. If infant is severely injured despite absence of CNS finding, then had CT scan, MRI, ophthalmologic examination. If abdominal trauma, then urine and stool for blood, liver, pancreatic enzyme, abdominal CT. For any bleeding, bruises, PT, PGD, we are also doing the coagulation profile just to rule out that there is no clotting problem. Medicine, the first step is to always to institute proper medical, surgical, or psychological treatment. Consider separating child from caregiver in exam area. Report any suspected child abuse. Report to CPS, CS worker conferred with MD. Law enforcement agency perform forensics, interview suspects, and if criminal act has taken place, inform prosecutor. Okay, and then written report required within 48 hours, and hospitalization is required if medical conditions requires it. Diagnosis is unclear, there is no alternative safe place, and parents refuse hospitalization treatment. MD must get emergency court order. Okay, this is the reason that medical condition either requires diagnosis is unclear. We are still doing some investigation. No alternative safe place. Parents refuse hospitalization. Then emergency court order. Then we have this thing. MD should explain to parents when an infected is suspected, legally obligated to report. Referral is made to protect the child. Family will be provided with services, and CPS worker and law enforcement will be involved. And court will ultimately decide guilt and disposal. The earlier the age of abuse, the greater the risk of mortality. Sexual abuse. A 3-year-old child curd presents with green vaginal discharge. Microscopic examination of the discharge revealed gram-negative intracellular diplopocci. This is trichomonas. No, this is I think a gonorrhea. Intracellular. Condyloma appearing after age 3 and trichomonas vaginalis, but green vaginal discharge will be in trichomonas. I think. But it's a flagellative organ. I don't know. Condyloma appearing after age 3 and trichomonas are probable diagnosis. HSV and non-venereal warts may be autoimmune. Yeah, HSV and non-venereal may be autoimmune. So this is not the a suspecting child effectively. Trichomonas and condyloma. Least common offender is a stranger. Most common by father and stepfather. Most common overall is brother-sister incest. Violence is not common but increases with age and size of victim, more likely to occur as a single incident with a stranger. Sexual abuse should be considered as a positive cause if presenting with vaginal, penile, rectal pain, discharge, bruising, erythema, bleeding, chronic dysuria, any urethritis, constipation, and copulation. Any STDs in pre-pubertal child is inevitable. Test for pregnancy, test for STD, test for syphilis, HIV, gonorrhea, hepatitis B. Okay, management is police CPS notification, psychiatric support, foster care placement, antibiotics, pregnancy, post-menarche, mid-cycle within 72 hours. Respiratory disease. Acute inflammatory upper airway obstruction. Group. This is a child, 12-month-old child, brought to the office because of a barky cough. Barky cough is group. Mother states that over past 3 days, child has developed runny nose, fever, cough. Symptoms are getting worse and the child seems to have difficulty breathing. He sounds like a seal when he coughs. So this is pathognomic for group. And he just has like runny nose, fever and cough and he has some difficulty breathing. Infective agents are parainfluenza. Age 3 months to 5 years, most common in winter. Recurrences decrease with increasing growth of airway. Inflammation of subglottis. This is inflammation of subglottis, so we call it croup. And upper respiratory tract infection, 1 to 3 days, then barking cough, hoarseness, inspiratory stridor, worse at night, gradual resolution over 1 week. Complication of hypoxia only when obstruction is complete. And then diagnosis is clinical, X-ray is not needed, steeple sign if an X-ray is performed. Treatment is basically supportive, but for more severe cases, nebulized epinephrine and followed by corticosteroid. That's it. Basically, it's supportive, so it will always on its own in 1 week or so. Then we have epiglottitis. Epiglottitis is a medical emergency that requires anesthesia for immediate intubation and emergent thyroidotomy. When 2-year-old child presents to emergency with her parents because of high fever and difficulty swallowing. Difficulty swallowing is the pathognomic. Then drooling and child has been in usual state of health but awoke with this is so sudden. Very high fever, 104, a hoarse voice, difficulty swallowing. On physical exam, the patient is sitting in a tripod position. This is drooling, inspiratory stridor again, nasal flaring, retraction of the supraesternal notch and supraclavicular and intercostal spaces. So this is person is going to respiratory insufficiency. Infective agents are hip, which is no longer the HIB, no longer the number 1 due to vaccination. Now are Streptococcus pyogenes, Streptococcus pneumoniae, Staph aureus, Mycoplasma. Risk factors adult or unimmunized. Inflammation of epiglottis and supraglottis. Signs and symptoms examination, dramatic, acute onset, high fever and all that stuff, toxic appearing. This is very important. Sniffing position, drooling, sniffing position. Stridor is a late finding near complete obstruction, then we will find stridor. Then complication, complete airway obstruction and clinical first. Do nothing to upset the child. Controlled visualization, laryngoscopy of cherry red, swollen epiglottis. X-ray is not needed. A thumb sign if X-ray is performed, followed by immediate intubation. Establish the patent airway, so we are just intubating this patient. Antibiotics tend to cover staph, hip, resistant, strep. This is anti-staphylococcal plus third generation cephalosporin. So something like flucloxacillin or naxalin, those things, plus a third generation cephalosporin. Yeah, cefotaxime, ceftriaxone, those stuff. And they have just a small comparison between croup and epiglottitis. Acute onset, and this is barking cough and respiratory stridor and seal, sound like seal, those things. This is drooling, sniffing position, tripod position, dysphagia, all this stuff. Yeah, high fever, very acute. And then we have the treatment. We know definitive treatment if needed for this group is just it's just they're giving single IM dose of dexamethasone, parenteral steroid. They are giving none on nebulized epinephrine. That's it. But for epiglottitis, we need airway intubation. We need antibiotics, anti-staphylococcal and third generation um, cephalosporins. And then we also do the sensitivities and then modify our treatment according to the sensitivity. In congenital anomalies of the larynx, laryngomalacia is the most common laryngeal airway anomaly and is the most frequent cause of spider in infants and children. Okay, collapse of supraglottic. This is laryngomalacia is supraglottic. Okay, less in prone. This will be less in prone. This is very important pathognomy for laryngomalacia. Starts in first 2 weeks of life, symptoms increase up to 6 months, typically exacerbated by any exertion. Clinical suspicion is confirmed with laryngoscopy, bronchoscopy, treatment with more supportive care. If significant, then we do a supraglottoplasty. May even that may prevent tracheostomy. So laryngomalacia is like a very benign thing. It can just be managed with the supportive care. You don't need to do anything. Congenital subglottic. This is subglottic stenosis is second most common, and this is recurrent or persistent group that is stridor. No difference to if we want to distinguish between the congenital subglottic and the laryngomalacia, there is no difference in the stridor between the supine and prone position. While the laryngomalacia was supraglottic and it was a like there was a difference. Like it was less during stridor was less during the prone position. Diagnosis airway X-ray confirmed with laryngo and the same surgery, but they are doing surgery. Cricoid split or reconstruction surgery. Then going next, vocal cord paralysis is the third most common. Okay, now this one is with often with like congenital malformation like Bacchiari, with like Chiari malformation like meningomyelocele, Arnold Chiari, I think. Maybe acquired after surgery from congenital heart defect or tracheostomy fistula repair. Okay, so it can be acquired after surgery, TF or congenital heart defect. And then bilateral is airway obstruction, high-pitched inspiratory stridor. Unilateral is aspiration. Unilateral will be aspiration and this will be obstruction. Okay. Diagnosis is flexible bronchoscopy. We'll do flexible bronchoscopy and treatment usually resolves in 6 to 12 months. May require temporary tracheostomy. Okay. So vocal cord paralysis usually resolves in 6 to 12 months. Nothing. You don't need to do a lot of things for it. Airway foreign body. Airway foreign body are toddler presents to the emergency center after choking on some oils. The um, child's mother believed that the child swallowed a quarter. On physical exam, child is noted to be drooling and in moderate respiratory distress. There are degrees were found on the right with intercostal retraction on the right. Okay. So larynx is the most common site before age 1 and in children greater than 1 think trachea or right main stem bronchus. Okay. Larynx in less than 1 and right main stem bronchus or trachea in greater than 1. Mostly seen in children 3 to 4 years. Most common foreign body is peanuts. Highly suggested if symptoms are acute choking, cough, wheezing, often are witnessed event. Depends on location, sudden onset cough, hoarseness, wheezing, asymmetric and decreased breath sound. So, foreign body removal is through most common form is through rigid bronchoscopy. So this was a difference, like when we were doing that facial bronchoscopy in the vocal cord mm, paralysis, and here we are doing visit because we need to remove that foreign body. And this is the ball valve mechanism, so we will find the aircraft. This is just X-ray that we need to do bronchoscopy for definite diagnosis and also retrieving that foreign body. Then we have inflammatory disorder of the small airways, neuropathic bronchiolitis, or a 16-month-old infant present with a 3 days to upper respiratory tract infection, wheezy cough, dyspnea. On physical exam, the patient has a temperature of 39, 102 degree Fahrenheit, respiration of 60 breaths. Oh my god, that's tachypnea, nasal tearing, accessory muscle release. Patient appears to be air humming and the oxygen saturation is 92%. RSV, 50%. Typical age is almost all children are infected by this less than 2 years. Most severe at age 1 to 2 months in winter months. Inflammation of the small airways, of inflammatory obstruction, edema, mucocellular debris, bilateral obstruction, air trapping, and overinflation. Then we have clinical presentation, mild upper respiratory infection upper from household contact, decreased appetite, fever, irritability, paroxysmal fever, cough, dyspnea, tachypnea, apnea more prominent early in young infants. Then wheezing, increased work of breathing, fine crackle, prolonged expiratory phase because there's some air trapping happening here. Last average of 12 days, worse in first 2 to 3 days, but yeah, it will ultimately go away. Bacterial super infection, respiratory insufficiency, failure, and diagnosis is clinical. Chest X-ray is not routine. Hyperinflation with patchy atelectasis may look like early pneumonia. Immunofluorescence of nasopharyngeal swab. It's not routine PCR. Then treatment is just supportive care and hospitalization with severe respiratory distress may give a trial of hypertonic nebulization. There's no role of steroids here. Ribavirin is not routinely used. May prevent the congenital ventilation in severe cases. Prevention is monoclonal antibody to RSV F protein, preferred is palivirudinib. In high risk patients, there's some immunocompetent or immunocompromised or some like premature preterm patients. We will give monoclonal antibody to RSV F, palivirudinib. Now our chapter is no, not finished. Pneumonia is 3-year-old child present with physician with a temperature of 40, unenforced tachypnea, wet cough. Patient sibling has similar symptoms. Child attends daycare but has no history of travel or fat exposure. Decreased appetite but is able to take fluids, has a good urine output. Immunizations are up to date. Inflammation of the lung parenchyma, viruses are predominant, and major pathogen is RS. Yeah, viruses are very dominant. Parainfluenza, influenza, I do know. Non-viral, more common in children greater than 5 years. So this is Mycoplasma and Chlamydia. Genus has been changed to Chlamydophilia. Okay, this is Chlamydophilia. As pneumonia is most common with focal infiltrate. Focal means as pneumonia. Okay, other than normal children as 5 S or is no longer Hib. Hib is not positive organism of pneumonia. Viral temperature is increased. The bacteria is very high temperature, then there's no upper respiratory infection. Here toxicity is like very toxic looking, and whales are scattered in viral and localized in bacterial. Okay, the VBC count is very high in bacterial. It's normal to decrease in viral. Lobar consolidation we often see, and then diagnosis blood culture, transtracheal aspirate that is rarely done. So blood culture is okay. Clinical findings viral. Usually several days of upper respiratory infection, low grade fever, most consistent manifestation, tachypnea, cyanosis, respiratory. Difficult to localize so with young children with hyperresonant chest. Difficult to clinically distinguish viral versus non-viral. Bacterial will be sudden shaking, chills with high fever, acute onset, and then productive cough, splinting on affected side, and minimize the pleuritic pain. Examination markedly diminished breath sound and dullness to percussion, low fever or wheezing. Chlamydia trachomatis pneumonia. It is 1 to 3 months of age, yes, it's very low. Staccato cough, peripheral eosinophilia, Staccato cuff is the interstitial chest X-ray findings may or may not have conjunctivitis, so it's not. No fever, wheezing distinguished from RSV. Then we go chlamydophila pneumonia and mycoplasma pneumonia. We cannot just distinguish clinical distinguish, so just bronchopneumonia there, coryza is usual, cough person with dyspnea, and whales are most consistent, so this is basilar. Okay, whale. Not just something that we can just see about it. Diagnosis is chest X-ray is helpful. Viral hyperinflation, bilateral interstitial fatigue, peribronchial coughing is for viral. So this thing. Pneumococcal is confluent lobar. Mycoplasma looks worse than presentation. Chlamydia is interstitial pneumonia or lobar as with mycoplasma. Chest X-ray often looks worse than presentation. And WBC count is viral, usually less than 20,000. Lymphocyte predominance. Bacterial is 15,000 to 4,000 with mostly granulocyte. Chlamydia is eosinophilia. This is very important. Definitive diagnosis: viral isolation of virus or detection of antigen respiratory tract secretions. Rapid reagents available for RSV, parainfluenza, influenza, ITNO. Bacterial sputum culture of no value in children, so there's no need of doing this sputum culture thing. We can do isolation of the organism from blood, pleural fluid or lung. Mycoplasma get IgM titers. Treatment based on presumptive cause, influenza appearance. Hospitalizes parental cefuroxime. Okay, hospitalizes cefuroxime is aureus suspected at Vanco or Clinda. Suspect viral, then may withhold treatment mild or no respiratory distress. Up to 30% may have coexisting bacterial pathogens. Situation should signal possible secondary bacterial infection to start empirical treatment. Chlamydophila or mycoplasma, erythromycin or other macrolide. So yeah, we treat them with macrolides and we treat the bacteria, other bacteria with parental cefuroxime. And if we suspect Staph aureus, then we give them either Clinda or Bento till we know the sensitivities. So we have all done this thing, and I don't think we need to do. Then we go to the next. Cystic fibrosis. 3-year-old child, white child, present with rectal prolapse. Yes, we know that this is more common in Ashkenazi or like those stuff like European descent and with rectal prolapse. She is noted to be in the less than like Caucasian, yeah, cystic fibrosis. 5th percentile for weight and height. Parents also know that she has a foul smelling bulky stool stage at fruits. Child has developed a repetitive cough over the last few months. Most common life-limiting recessive trait among boys. Major cause is severe chronic lung disease. Most common cause of exocrine most common cause of exocrine and carry deficiency in children. So, this is exocrine. Primary pathogenic feature is dysfunction of epithelialized surfaces, obstruction, infection, airways, mild recession, autosomal recessive, northern and central European, Scandinavians. All of the gene mutations occur as a single locus on long arm of chromosome 7. CFTR is an ion channel regulatory function. The course called CFTR, cystic fibrosis, transmembrane protein, transmembrane, I think, receptor protein, something like that. Expressed mostly on epithelial cells of airways, GI tract, sweat gland, genitourinary urinary. Not all children can be identified by DNA testing. We need to sequence CFTR. Okay. Then we had this thing all pathogenesis and pathology. Membranes of CF epithelial cells unable to secrete fluoride in response to cyclic CAMP mediated sickness. Okay, unable to secrete fluoride. Okay, failure to clear mucous secretion. They are very paucity of water, very viscous, increased salt content of soil, so increased sweat chloride. Manifestations are bronchial obliteration and bronchiectasis, opacified paranasal sinus, large polyps. pancreatic dysfunction, fat and fat-soluble vitamin malabsorption, intestinal gland distended mucus secretions, focus, biliary cirrhosis, then endocervicitis, protein tail of epididymis, and all that is obliterated in apathetic in males. Then intestinal tract is usually first 10% of first they will have their meconium areas, then prolonged jaundice and access shows dilated loop, their fluid level, ground glass, probably appearance material in lower central there is meconium areas now. Gastrographinema is reflux into ileum may clear, but if not then so gastrographinema we do this for meconium areas. Most fat malabsorption from pancreatic exocrine insufficiency, frequent bulky greasy stool, failure to thrive, fat soluble vitamin A, D, E, K. And then we have this hepatobiliary ascites, icterus, hepatomegaly, cholecystokolitis. Pancreas increase incidence of diabetes mellitus and acute pancreatitis, rectal prolapse happens in most pancreatinuria, malnutrition, cough. Respiratory tract rate of progression of lung disease is chief determinant of mortality and morbidity. Early in life, non-typable H. influenzae and S. aureus. Then colonization with Pseudomonas aeruginosa. Then later colonization with Burkholderia crepacea. Burkholderia crepacea that is associated with rapid deterioration and death. This is the end stage. Cough, purulent mucus early in first year, extensive bronchiolitis and pulmonary function test, abnormalities, dyspnea, finally cause pulmonary respiratory failure, death, high risk of pneumonia. Exam is increased AP diameter, hyperresonance, respiratory wheezing, clubbing, cyanosis, sinuses are almost always present. Almost all males with azoospermia, increased incidence of hernia, hydrocele, undescended testes, female secondary amenorrhea, decreased fertility, sweat gland, excessive loss of salt depletion, especially with hot water or gastroenteritis. So serum hypochloremic alkalosis, salty taste of skin. Diagnosis is typical clinical features. Diagnosis any of the following plus any of the following is typical clinical features: history of sibling with CF, positive newborn screen, plus there can be two increased fat chlorides on two separate days, identification of two CF mutations, homozygous, and increased nasal potential difference. Yes, this is also very important. Increased nasal potential difference. Sweat test is the best test, difficult in first week of life, confirm positive results, and diagnosis is greater than 60. Then if sweat test is equivocal, then we go at the potential difference across the nasal epithelium. We check it. It's increased pancreatic function 72 hours, fecal fat collection, food for trypsin, pancreozyme secretin stimulation, serum immunoreactive trypsinogen increase in urine. X-rays, hyperinflation of chest, nodular densities, vegetative lip gases, ongoing infiltrates, island nodules. With progression, flattening of diaphragm, external bowing, narrow cardiac shadows, cysts, extensive bronchiectasis, pulmonary function test. By 5 years, obstructive pulmonary disease, then restrictive. Okay, by 5 years, they already have obstructive, then they have restricted that fibrosis as microbiologic finding in sputum of S. aureus followed by P. aeruginosa newborn is virtually diagnostic. This is virtually diagnostic. But also B. cepacia, but usually it is a late finding and then death occurs. Antenatal diagnosis by mutation analysis in family previously identified by birth of child with CF test, spouse of carrier with standard panel of probe. Newborn skin, determination of immunoreactive trypsinogen in blood clots, and then confirmation with sweat or DNA testing does not improve pulmonary and therefore long-term outcome. Treatment is clear airway secretions, control infections, aerosol treatment, albuterol and saline and daily recombinant DNA is mucolytic and what else? Chest physical therapy with postural drainage. Then antibiotics for acute infection most frequent is aerosolized is topramycin. Yes, we are giving this. Most frequent P. aeruginosa must base choice on culture and sensitivity. For acute infections, change in baseline conditions, then we give antibiotics, and then hospitalization is progressive despite intensive home measures. Typical 14-day treatment, 2 drug regimens to cover pseudomonas. Example, piperacillin plus tobramycin. So tobramycin already we were giving aerosolized, now we are giving piperacillin plus tobramycin or ceftazidime. Nutrition is pancreatic enzyme replacement, meals, snacks, vitamin supplementation, adequate fluid replacement when exercising or hot weather. Okay. So basic is like chest physical therapy, and we are giving them aerosol treatment, albuterol and saline, and human recombinant DNAs. Then antibiotics if there is like difference in change in yeah, so aerosolized antibiotics can be used for inflammation, like change in the baseline. Hospitalization with 2 drugs treatment, piperacillin plus tobramycin or ceftazidime. Ceftazidime, okay, and then pancreatic enzyme replacement, adequate fluid replacement when exercising or hot weather. They haven't tell us anything about ivacaftor. 2-month-old term infant born with no complications via spontaneous vaginal delivery is brought to the emergency center via ambulance with CPR in progress. According to the mother, the patient was in his usual state of good health until 4 a.m. when she found him cyanotic and not breathing. At midnight, the infant was fed 4 ounces of formula without any difficulty and then placed to sleep in a crib. At 4 a.m., the mother returned and found the child unresponsive. She immediately called emergency medical services and began CPR. Child was pronounced dead on arrival at emergency department. This is sudden infant death syndrome. That is unexplained and just sudden unexplained infant death syndrome. SUDS. We call it SUDS now. Okay, and before 1992 it was considered 1 is to 4, but back to sleep campaign 0.45, and not explained is said intentional suffocation. There's no pathology, no findings. Nothing is diagnostic. You cannot find anything on it. Critical hemorrhage is very non-specific malaria edema. Low socioeconomic status, these are non-modifiable. African American, Native American, highest at 2 to 4 months, most by age 6. Midnight to 9 a.m. highest in winter as males greater than females. Modifiable are shorter interpregnancy interval, less prenatal care, low birth weight, preterm IUGR, maternal smoking, and postnatal smoking. These are modifiable. Sleep environment, higher incidence related to prone. Supine position now better than side sleeping. No increased problem in supine, that is aspiration, higher incidence of soft bedding, overheating, pacifier shown to consistently decrease risk. Pacifier is one thing that can decrease the risk. And also put feet at the sleep to back and feet at the feet end. Episode of apparent life-threatening event. Recently new nomenclature is brief resolved bruise. Brief resolved unexplained episode. This is recent subsequent sibling of SIDS victim prematurity home mortgage do not decrease risk. Reducing risk supine when sleep. Use script that meets federal safety standards. No soft surfaces, no soft material, no bed sharing, overheating, over bundling. Use prone position only when the patient is awake. And no recommendation for home monitoring for this purpose, and expand national back to sleep up to 25% of infants still sleep prone. Okay, so starting the allergy and asthma chapter. So we'll try to finish it very fast. Allergic rhinitis, differential diagnosis of eosinophilia, neoplasm, asthma, allergy, resistance, allergic vascular diseases, parasites. So generally established by age 6, inconsistent early introduction of formula versus breast milk or solids. Mothers smoking before ages 1 year old, heavy exposure to indoor allergens, most perennial key symptom with greater exposure. So diagnosis is suggested by typical symptoms in absence of upper respiratory infection, structural abnormality, pulse at night with snoring, mouth breathing, watery itchy eyes, postnasal drip with cough, possible wheezing, headache. Allergic salute. This is like sort of like recurrent itching sort of thing, and then person is scratching, so nasal freeze, vigorous grinding of eyes with thumb and the side of the fist. History of symptoms with timing and duration. exposure setting from the street, food allergies. Then we have physical exam. Allergic shiners are the venous tests, blue, gray, purple beneath the lower eyelids, often with Denny lines, prominent symmetric skin folds. Denny lines, that's allergic shyness. Chemosis and a must-windy discharge, cobblestoning of the tarsal conjunctiva. Then we have transverse nasal crease from allergic salute, and then pale nasal mucosa, turbinate hypertrophy, polyps, postnasal drip. Differential is non-allergic inflammatory. There is no IgE. Antibodies is non-allergic. Vasomotor from physical stimuli. Nasal polyps, think of CF. Nasal polyp also in the asthma or central sprite, aspirin sensitivity. Septal deviation, overuse of topical vasoconstrictors, rare plasm gangliomatous disorder like vaginal. And we have peripheral eosinophilia, eosinophil nasal bronchial secretion more sensitive than blood, eosinophils. Okay, nasal is more sensitive, nasal and bronchial more sensitive than blood. IgE is increased advantages. IgE is specific allergen in blood draw. Advantages safety. Result will be uninfluenced by skin disease medication, while major disadvantages are its expense and less sensitivity. Best uses for extensive dermatitis than with IgE specific allergen in blood draw. Okay, and then in vivo skin test is best. Treatment is environmental control plus removal of allergen is most sensitive method. Yeah, this is the most, yeah, like remove the allergen, whatever is causing allergy, just remove. HEPA filter, vacuuming, dehumidifiers, carpet removal, pillow mattress encasement, remove pets, no smoking, no wood burning stoves, avoidance of biggest triggers like house dust mite, cat, cockroaches, those things. Pharmacologic control, antihistamines are the first therapy. First generation are diphenhydramine, chlorpheniramine, brompheniramine cross the blood-brain barrier, so they cause sedation. Second generation, they are preferred now. So these are the cetirizine, Fexit, and loratadine. Fexofenadine, loratadine. These are now preferred, easier dosing, no sedation, like somewhat lesser sedation. Oral antihistamines are most effective than chromin, but significantly less than intranasal steroids. Efficacy is increased when combined with an intranasal steroid. Okay, so if you combine an oral antihistamine with intranasal steroid, then efficacy will be increased. Intranasal corticosteroids are more effective medication, but not first line. Effective for all symptoms like antihistamine. Then we have this leukotriene receptor antagonist, hormones, bromelain and nadoclonine sodium. These are least effective, very safe with prolonged use. Best for preventing unavoidable allergy. Decongestants, topical form oxymetazoline, significant rebound. These are alpha adrenergics, so they have a significant rebound with decongestant. Oxymetazoline and phenylephrine. Then epinephrine alpha beta drug of choice for anaphylaxis. Immune therapy decreases or eliminates the person's adverse response of secret natural exposure. Major indication is duration or disabling, and you cannot um, like, get this irritant off. So this is the treatment for choice for insect desensitization. This is basically, I think, desensitization sort of thing. Um, so insect venom is like immune therapy. Like you are administering the gradual increasing dose of allergen mixture. Should not be used for like atopic dermatitis, food allergy, latex, urticaria, children age less than 3, too many system syndrome. So we are just using it for insect venom desensitization, like bees and those stuff. Then we have complications of allergic rhinitis, chronic sinusitis, asthma, eustachian tube obstruction, miliary effusion, tonsil, adenoid hypertrophy, emotional, psychological problem. Insect venom allergy. Well, this is from the order of Hymenoptera. This is yellow jackets are most notorious, aggressive, ground dwelling, and linger near food. Okay. And systemic, this is anaphylaxis, delayed response, most pursue skin testing. Treatment is like local cold compress. Remove the stingers by scraping. Stingers are removed by scraping. Anaphylaxis and EpiPen. Just give that person EpiPen. If just the person is having itching, those things, then just give oral antihistamine. Indication of immune therapy is severe reaction plus positive test. Then you give, and this is highly effective and decreasing the risks. And we know that whenever we are doing desensitization, we need to stop beta blocker because it can mask those food reactions. Most infants and young children outgrow the milk and egg allergy half in first 3 years, and majority with nut and seafood allergy retain for life. So this is very important. Nut and seafood allergy retain for life. Other than that, allergies usually they like wane away. Uh, Most food allergies are egg, milk, peanut, nuts, fish, soy, wheat, but any food may cause a food allergy. Food allergic reactions are more common cause of anaphylaxis seen in emergency. With food allergy, there is an IgE or cell-mediated stress. Okay. Food allergies, IgE. Then we have skin, urticaria, angioedema, flushing, atopic dermatitis, GI, vomiting, diarrhea, abdominal pain, cell-mediated response. So standard allergy tests are of little value. Food protein is equal to induced enterocolitis, proctocolitis presented with bloody stool diarrhea, most cow milk, soy protein allergies. They are like bloody diarrhea. Okay. These are cell mediated IgE. Yeah, we did this. These are cell mediated IgE or a cell mediated. Most are like respiratory, wheezing, asthma, hypotension, and must establish the food, amount, eating, timing, nature of reaction. IgE specific allergen skin tests useful for IgE sensitization. Negative skin test exclude an IgE mediated, but because of cell mediated response, we need a food elimination and challenges in a controlled environment. It is the best. Only validated tests, like they are saying that negative skin test can exclude an IgE mediated, but because of cell mediated, we need the elimination and then challenging it. That is the best. Only validated treatment is elimination and EpiPen. That's all. Then we have urticaria and angioedema. It can happen with anything because of activation of the mast cell. Acute is less than 6 weeks. Chronic is more than 6 weeks. Okay. So it can happen with anything, but just stimulate the mast cell and that thing can happen. Even TBE, hepatitis B also. Hereditary angioedema is important. C1 esterase inhibitor deficiency, autosomal dominant is important. Recurrent episode of non-fitting edema diagnosis may be clinical. And skin test, IgE, specific allergens. Most respond to trigger and oral antihistamine. Severe EpiPen. If H1 antagonist does not work, then H1 plus H2 are effective considered for chronic refractory edema, angioedema, IVIG, then we get plasmapheresis. Why not induction? We used to get this for hereditary C1 esterase inhibitor deficiency. Just check it. So, not induction. This was yes, Acylantide is used for hereditary angioedema. I don't know why they are not using it. In MTB was there. Okay, then we have I will just write this down. Acylantide. And we have anaphylaxis, out of hospital food and in hospital latex and antibiotics, IVIG, and these things can occur within 2 minutes to 2 hours. And then treatment is injectable epinephrine, oral liquid diphenhydramine, transfer to ER, and airway management. Epinephrine IM, short acting beta 2 agonist, S2 antagonist of oral allergen. We have total atopic eczema, atopic dermatitis, eczema. So this is starting by age 1, most by 1 and 5, and chronic relapsing, intense cutaneous reactivity, pruritus, worsen, night scratching, induces lesion become excoriated, and then excessive sweating, irritants. These are the exacerbation with food, meal, and vaccine infection, decrease humidity. Erythromatous papules, intensely pruritic, serous exudate, excoriation. Lichenification is thickening, darkening. And then, oh my god, this is like severe subacute and chronic atopic dermatitis most commonly affects the flexure surfaces of joints. Then we have face, scalp. Flexure is flexural surfaces, yes, where the friction. So often a inflammation with age, but skin left prone to itching, inflammation, and exposed to agents. And identify and eliminate T positive and the emollients. So they are the biggest cutaneous cutaneous hydration. So dry skin, especially in winter cirrhosis, topical corticosteroids, 7 classes. The higher potency classes are not meant to be used on face or intertriginous areas and only for short periods. Goal is the emollients and short potency steroids for maintenance, and we have to use them for a very small time. This is the main thing. So we are not using steroids on face or intertriginous areas. Okay, and only use for short period. That is a mainstay. Okay, we don't want to make it more worse because steroid predispose you to infections. Topical immunomodulator like tacrolimus, calcineurin inhibitor, inhibit activation of T cells. Ointment safe and effective, safe on face. Okay, tacrolimus is safe on face. This is calcineurin inhibitor. Can use as young as 8 to 2 years. Okay, tar preparation, phototherapy. We can't use tar on yeah face black thing. Phototherapy, UV light, systemic antihistamine, sedating and night for pruritus, glucocorticoids, cyclosporine refractory to all treatment, interferon if all else fails. Treat with antibiotics for bacterial superinfection. Complications are secondary bacterial infections, especially as early as these incidents of T. rubrum, M. furfur, recurrent skin infections, Kaposi varicilliform eruption, eczema herpeticum, most common. So recurrent viral infections. So you get this warts. But the most common thing is secondary bacterial infection. Case incidence of T. rubrum, M. furfur, meniscevia, furfur. Okay. Contact dermatitis. This is just like something is coming in contact and causing that reaction. We hypersensitivity to reaction. This is type 4. Okay, and jewelry and clothing and poison ivy diagnosis clinical supportive eliminate the contact and that will be good. Okay, asthma is a 6-year-old boy present with the physician with angus expiratory wheeze scattered throughout the nose. Noted to have nasal flaring, tachypnea, intercostal contractions. The symptoms are triggered by changes in weather. Family history of eczema, of asthma and atopic dermatitis. Never been intubated or admitted. Last hospitalization for asthma was 6 months ago. He takes medication for asthma only when he starts to wheeze. So now he is coming with wheezing. Okay. So now I think this is not controlled. With all asthma categories, step up, step down dosing is typically used. High at first and down to minimum necessary to prevent symptoms. Older children can use a metered dose MDI. Young children often do it with a spacer and face mask. Okay. Younger face mask and older MDI. Infant may need to have nebulized. Infants nebulized. Then we have the note thing. Uh, Adjunct treatment to prevent intubation and ventilation, IV beta agonist, IV scopolamine, Heliox, IV metsulfate. Okay, okay, they are using beta agonist, they are using scopolamine, Heliox is helium increase every and clinical response in 20 minutes. Okay, and IV metsulfate is a smooth muscle relaxant. Monitor BB every 10 to 15 minutes for the risk of hypotension. So, like short acting beta agonists, then they are giving the IV theophylline and Heliox, like 30 to 70, 70 to 30. So 70% is helium and oxygen is 30%, and then goes to the IV metsulfate and epidemiology. Okay. We know this thing. Less than 6 most resolved by late childhood. Two main pattern: early childhood by viral, chronic is allergies. Early childhood is viral, and chronic is allergies. Okay, this often goes into adulthood. Some risk factor for persistent asthma, peritonitis, atopic dermatitis, allergic rhinitis, food allergy, severe lower respiratory tract infection, breathing other than upper respiratory infection, exercise, emotion, food stuff. We just need to see the clinical presentation. We know real bronchi, excessive mucus inflammatory, pronounced respiratory failure, blood of breathing. In children, neither left as not provocation. Okay, they may support the clinical and maybe use to follow the patient plan. Neither, nothing. Lung function is like because when they are 6, then we do this spirometry thing. The gold standard is spirometry during forced expiration. FEV1, then you will find FEV1 FEHC ratio less than 0.8 airflow obstruction in 1 second adjusted to the full in children age greater than 5 years. Okay. Bronchodilator response to inhaled beta agonist improvement in FEV1 to greater than 12%. Exercise challenge worsening in FEV1 of at least 15%. Improvement was of greater than 12%. First, we found that it's less than 0.8, then we gave the bronchodilator, response was greater than 12% improvement, and then worsening will be at least 20% or 15%. Yeah, this is metafolding challenge test or exercise challenge test. Home tool is PEF. PEF is the home tool. It's very good, but it can like tell us what's going on like daily. AM and PM PEF for several weeks for practice and to establish personal best. Yes, that's yes. AM and yeah, for several weeks to practice and establish personal best and to correlate to the symptoms. Based on personal best, divide PEFs into zones. Green and green is 80 to 100%, yellow is 50 to 80, and red is less than 50%. So this is PEF, that is home monitoring. Hyperinflation, peribronchial thickening, usually by the asthma, aspiration, GERD, or other like severe exacerbations. Treatment based on asthma severity classification. Symptoms less than 2 symptoms. Yeah, this chart is very good. Less than 2 symptoms. Symptoms less than 2 days per week and less than 2 days per month. That's so good. This is intermittent. No need for daily controller, just as needed. Short-acting beta agonist. Then persistent, mild, moderate, or severe. Now symptoms are greater than intermittent. Now need a daily control. This one is intermittent. We have done it, and then mild persistent is greater than 2 per week and greater than 2 per month. So this is inhaled steroids and beta agonist for breakthrough. Moderate persistent is daily. Now this is greater than once per week. This is so much. Like this is more than 4 times per a month. This is once per week, and then this is inhaled steroids, LABA, SABA, nicotine receptor antagonist. Okay. Then we go on to severe persistent, continuous, limited activities, frequent exacerbation, frequent. Now we are giving LABA, SABA, inhaled ICS, systemic steroid, nicotine receptor antagonist, and then quick relief medication are the SABA, short-acting beta-2 agonist, albuterol, levalbuterol, nebulized monitor, butylene, levalbuterol, metaproterenol, rapid onset may last good, drug of choice for rescue and preventing exercise-induced but inadequate control if need greater than 1 canister per month. Then this is an inadequate control. Yeah. So this is metaproterenol. Albuterol, levalbuterol, and terbutaline, and metaproterenol. Then we have anticholinergic muscular potent ipratropium bromide for acute severe asthma in ED and hospital. Short-acting, short course of systemic steroids patient for moderate to severe flare-up. Prednisone 3 to 7 days inpatient recommended with IV methyl prednisone, but the studies have shown that oral and IV There's no difference. Yeah, we can give, I think, first try oral, and we will only give IV if the patient is like severe vomiting and cannot take oral. Management of asthma exacerbations, monitor oxygen as needed. Inhale albuterol every 20 minutes for 1 hour. Add hypertropium if no good response for second dose. Okay, the first thing is oxygen, then albuterol every 20 minutes for 1 hour. Hypertropium if no good response for second dose. Then we have the steroids, corticosteroids for oral IV. We can go home with sustained improvement in normal physical findings in SaO2 greater than 92% after 4 hours in room air, and PEF is greater than. So these are the criteria for can go home with sustained improvement. Like SaO2 after 4 hours is okay in room air, and PEF is greater than 70% of personal best. In home on every 2 to 3 hours, MDI plus 3 to 7 day oral steroid. For moderate severe flare up without improvement within 1 to 2 hours of initial acute treatment, and PF less than 70, then you give oxygen nebulized albuterol and add hypertropium every 6 hours and IV steroids. We need IV fluids. Mechanical ventilation is there only when we need silent chest or acidotic and all that stuff. Respiratory rate extremely high. Then bronchiolitis and asthma, they have like compared. So this is like upper respiratory tract infection, getting worse, fever, tachypnea, bilateral expiratory wheezing. It has some things from asthma, some similarities, like but basically it's infectious, fever, tachypnea. Those things are not happening. And yeah, asthma can also occur with respiratory, upper respiratory infection. Yeah. A non-make diagnosis of asthma first time wheezing in infant with fever. Diagnosis is bronchiolitis, exactly. Then the clinical diagnosis. Bronchiolitis, we were just giving supportive treatment and nebulized hypertonic saline and yeah, nothing else. Then asthma was chronic. So this is immune mediated disease. We are doing. So this is a very important chapter, immune disorders. Evaluation of suspected immune deficiency. B cell is recurrent bacterial staphylococcus, Haemophilus, Campylobacter, viral, like everything is happening in B cell. 5 to 7 months of age or greater childhood to adult. Okay, 5 to 7 months, I think this one is gluten, and later childhood to adult will be the X-linked gamma 8 glucotamine, something like that. No, so I'll just check. This one is which one is this? This one I know X-linked gamma glutamine something glutens, yeah. And this one is I think severe combined or it's just combined. Infections are most are recurrent. Sinopulmonary infections are recurrent enteroviral meningitis. So this is sinopulmonary and enteroviral. Recurrent enteroviral meningitis also. Then autoimmunity is lymphoreticular and malignancy. Okay, if we will find autoimmune conditions here, lymphoreticular malignancy. Then screen with IgA if low, then measure IgG and IgM. Quantitative immunoglobulin. Okay. First thing is IgA. If it is low, then we move on and forward measure IgM and IgG because this is quantitative immunoglobulin. Then low antibody titers to specific antigen isohemagglutinin in vaccines. Then specific tests are enumerate the B cells with flow cytometry. Okay, we do flow cytometry and we find how many B cells are there. Monoclonal antibodies to B cell specific CD antigen, B cell absent or present, and number. Okay, so we are doing this flow cytometry to see how many B cells are there. Are they absent or are they present? Okay, so this one was B cell. B cell was causing autoimmunity, lymphoreticular malignancy was causing the sinopulmonary and antiviral and meningitis. So this was T cell. Now coming to T cell, opportunistic organisms, CMV, EBW, varicella. So this is opportunistic. That was recurrent bacterial and viral, but now this is opportunistic. So they will be in T cell. Usually 2 to 6 months of age. So mucocutaneous candidiasis. This is very important. Mucocutaneous candidiasis means T cell. Chronic diarrhea and failure to thrive. Post-vaccination dissemination varicella. Okay, this happens because that compromise. BCG hypocalcemia in infancy. Okay, graft versus host disease from transplacental paternal engraftment or non-irradiated blood. Lymphocyte count is low in T cell deficiency, and best cost-effective test for T cell function is Candida skin test. Candida skin test. Okay, this is best cost-effective test for T cell. So mucocutaneous candidiasis T cell and Candida skin test, and yeah, and otherwise lymphocyte count was low. That's what best. And specific test was the flow cytometry using monoclonal antibodies recognizing now T cell main flow cytometry. Okay, then phyta hemagglutinin, canavalin A, copied mitogen. Now this is T cell. Basic thing was hypocalcemia in infancy, BCG, graft versus host disease, post-vaccination dissemination of varicella. And these guys have chronic diarrhea and failure to thrive. So this is opportunistic organisms that are causing T cells. So this is pulmonary GI infection. Then we have complement. Candida is very important here. EBV is important. Pneumocystis cerevisiae, mycobacteria. Complement is pneumococci and Neisseria. So this is just like the spleen thing, I think. Spleen also has the pneumococcus and the Neisseria. The capsulated is complement. NEH and meningitis, arthritis, septicemia, recurrent sinopulmonary infection, autoimmune disorders. So this also has like meningitis, arthritis, okay, arthritis, angioedema. Screen is total hemolytic complement will be depressed if any component is consumed. Identify the mode of inheritance. All are autosomal except for properdin deficiency. Properdin deficiency is X-linked. Other than that, all are autosomal. Okay. And then can is any major C3, C4. So just do the C3, C4 and then you will find complement deficiency. So you know this area and pneumococcal. Okay. And then for each, the most accurate test is molecular genetic diagnosis. Okay. This is also important. And then we just go to the neutrophil. Neutrophil deficiency will be bacterial, that is Staph, Pseudomonas, Serratia, Klebsiella, Salmonella, fungus, Candida, Aspergillus. And this is skin abscesses is very important. Suppurative adenitis, gingivitis, oral ulcers, osteomyelitis. So these things are happening in neutrophil deficiency. Prolonged attachment of umbilical cord, this we will find this thing. And poor wound healing, decreased signs of infection. Neutrophil count will be low here, and neutrophil respiratory burst. This is for neutrophil deficiency. Neutrophil respiratory burst after for ball Easter stimulation. Most reliable non uses rhodamine fluorescence. Okay, NBT is neutrophil burst. This is replaced by rhodamine fluorescence. So they use for neutrophil either burst after respiratory burst after for ball steroid stimulation or rhodamine fluorescence replaced by NBT test. Can identify leukocyte addition deficiencies with flow cytometric analysis of leukocyte addition problem. Okay, neutrophil problem. Now we come to the specific defects. Defects of antibody production. X-linked gluten A gamma globulin. It's a profound defect in B cell development, leads to an absence of circulating B cells. And this has small, all the like B cell production areas are low. Small to absent tonsils, no palpable lymph node. Okay. Genetics is greater than 500 known mutations. This is necessary. Long arm of X. Boys with pyogenic sinopulmonary infection. So this is X-linked gluten, the A gamma globulin. So when we see the clinical picture plus lymphoid hypoplasia on exam, all immunoglobulin severely depressed, flow cytometry, absence of circulating B cell gene, required for gene sequencing for specific mutation, and treatment is appropriate use of antibiotics and regular monthly IVIG and antibiotics. This is the total. So boys with cyanopulmonary infection is X-linked gluten, A gamma globulin. The only two B cell defects for which stem cell transplantation is recommended are CD40 regain defect, extremely rare, one of the known mutation of the X chromosome, and X-linked lymphoproliferative disease. I don't think we need to remember this. Common variable immunodeficiency is CVID, the hypogammaglobulinemia with phenotypically normal B cells. Blood T lymphocytes do not differentiate into Ig producing cells. Okay, so this is common variable deficiency. It is just like Bruton's X-linked, but the problem is that they just B lymphocyte do not differentiate. So genetics majority have no identified sporadic, and then clinical equal sex distribution, later onset infection. Clinical, like this is just like Bruton's that is presenting like late onset, like 17, 18 years old adolescent or young adult. So we have IgG antibodies and profound and normal sized lymphoid tissue, later autoimmune disease and malignancy. So malignancy chances here increase. Need to be screened for anti-IgA antibodies as in selective IgA deficiency. If present, therapy consists of one Ig preparation available that contains no IgA. Okay, so yes, this is very important because if someone is like this, we see anti-Ig antibodies. So whenever we are giving them any transfusion, any like infusion, we need to make sure that they don't have IgA in them. So we will wash out. And then we have selective IgA deficiency. Selective IgA is the most common immunodeficiency caused by absence or phenotypically normal B cells. Families with CVID and familial pattern, and then very low to absent serum IgA with other Igs are normal. Okay, as with CVID, incidence of autoantibodies, autoimmune reaction, malignancy, serum antibodies to IgA can cause severe anaphylactic any blood product. This is very important, not a transfusion reaction. This is not a transfusion reaction. IVIG is not indicated because if usual IVIG is given, patients are at risk for severe reaction. So we just treat the infection because this is generally milder. So just treat the infection, whatever happens. Okay. Defects of cellular immunity, T cell defects. Now we have DiGeorge syndrome. Was thymic hypoplasia. DiGeorge is thymic and parathyroid hypoplasia. Okay. And to aplasia from dysmorphogenesis of third and fourth pharyngeal pouches. Other structures involve great vessel anomalies, right-sided aortic arch, interrupted aortic arch, aplasia, bifibula, congenital heart disease, and I think this is catch 22. Facial dysmorphism, short filtrum, thin upper lip, hypertelorism, mandibular hypoplasia, low set of nostrils, and cleft palate. So the rest of the associated T cells are extremely unknown only to immunologists and not seen on exam. Genetics microdeletion of 22q11 to DiGeorge syndrome, chromosomal region. 22q deletion also seen in velocardiofacial syndrome and chromotruncal anomaly. Catch 22 is cardiac, then abnormal facies, then P is for thymus hypoplasia or aplasia, and then C is for cleft palate, and H is hypocalcemia. Cleft palate, this one was cardiac. And then partial DiGeorge is more common with variable thymus and parathyroid hypoplasia. About 22 they call it because it is 22 to 11 22. As a must confirm diagnosis of complete form of molecular genetics, fatal without definitive treatment. Okay, DiGeorge have charge association. Okay, 1/3 of the DiGeorge is catch-22 has charge. Okay, clinical findings are severe opportunistic infections, graft versus host disease. Thymus is low, so T cells are low. Neonatal hypocalcemic seizures. Okay, yeah, and most moderately or low absolute lymphocyte count with variability per degree. Okay, must get a T cell count on all infant born with primary hypoparathyroidism. Okay, charge, truncus arteriosus, interrupted aortic arch. Treatment is complete form is corrective with their culture, unrelated thymic tissue transplant of bone marrow, peripheral blood transplant from HLA identical sibling. Okay, this is correctable through like bone marrow or peripheral blood. Kaplan. Okay. Then we have combined antibody and cellular immunodeficiency. Severe combined immunodeficiency, SCID. The for combined variable, and this is severe combined immunodeficiency, is the absence of all adaptive. Everything is absent. So this is the most severe immunodeficiency known. Because the natural killer cells and everything is. So, and then what happens is most common form X-linked is most common. There is clinical finding, severe combined first 1 to 3 months, recurrent person diarrhea, opportunistic infection. So this has like B cell low and T cell low. Continues to live without care because B cell related infection with develop. The X-linked has a low percentage of T and autosomal recessive form more common. Yeah. ADA deficiency affects the ADA deficiency. What is ADA deficiency? Yeah, this is ADA in here, no? ADA is missing the minus something. ADA deficiency affects typically T cell and deletions of. Okay, second most common is deletion of hormones. The stem cell transplant is the answer for this severe combined immunodeficiency. Okay, without it, most people will die in first year, but if diagnosed in first 3 to 4 months and treated, 94% will survive. The ADA form and H-link have been treated with somatic gene therapy. Become combined immunodeficiency, the presence of low but not absent T cell function and low or but not absent antibodies. Patients survive longer but have failure to thrive and still die relatively early in life, which are Scott-Aldrich syndrome. Scott-Aldrich is impaired humoral immune response, highly variable concentration of the IgGs with moderate reduced T cell and variable mitochondrial response. Genetics X-linked recessive, and I don't need to do this. And this WASP is Scott-Aldrich syndrome protein. WASP, that is encodes that cytoplasmic protein. Thrombocytopenia, atopic dermatitis. So yeah, so Scott-Aldrich is like we have eczema with we have low platelets and recurrent infection. So this is Scott-Aldrich um, syndrome was this triad, okay, and so anytime we see eczema with thrombocytopenia and infection, immune deficiency, then Scott-Aldrich will come in our mind. Clinical and molecular genetics, most common IG pattern is low IgM, high IgA. IgA is high here, and IgE, and normal to slightly low IgG and variably reduced T cell. So IgA is high and rare survive beyond adolescence without a bone marrow transplant. But breathing infections, EBV associated malignancies, and autoimmune complications. So this was X-linked recessive. Then we come to the ataxia telangiectasia. It's a moderately depressed testosterone and B cell mitosis. And like there is this, like ataxia. One thing is ataxia. So until age 10 to 12, they just are confined to wheelchair. Then we have the oculocutaneous telangiectasia, and then we have recurrent infection. So ataxia combined with telangiectasia, it is ataxia telangiectasia. And then we have this thing. Okay, but I just don't know that whether it is an autosomal dominant or which one is this. So I need to just check it. This is autosomal recessive. AT is AR. Okay, so and then we want to, and then recurrent sinopulmonary infections and malignancies, adenocarcinomas, and okay, and then supportive care. We just give them supportive care. And disorders of phagocytic function. This is like natural killer cell and this neutrophil. So decreased inflammatory response in the presence of neutrophils. So neutrophils are there, but they are unable, like their function is poor. So what will happen? It exists exiting of from addition to this is like they can't add like to the addition to the microorganism, they can't kill them. It promotes phagocytosis activation of NAPS oxidase, this ions which kill the microorganism. Clinical findings are infant with recurrent low-grade bacterial infection of the skin, large chronic oral ulcers with polymicrobe and severe gingivitis, respiratory tract and genital mucosa, delayed suppression of the umbilical cord with found phlebitis. Typical signs of inflammation may be absent, no pus formation, most organisms are S aureus, gram negative. Okay, so it's happening with S aureus and gram negative and Candida and Aspergillus. Okay, everything is happening. Circulating neutrophil count is significantly elevated, although there is paucity of neutrophils in affected tissue. Okay, if we see the paucity of affected tissue, but increased neutrophil count. So, because the assessment of we have to do a qualitative assessment of neutrophil, monocyte adherence, aggregation, chemotaxis, phagocytosis are all abnormal. Flow cytometry showing low CD15 on the neutrophil. Early allogenic stem cell transplant for severe forms, otherwise supportive care. Chronic granulomatous disease is when neutrophil and monocyte phagocyte but cannot kill. Okay, that one was addition and tissue migration thing, and this leukocyte addition deficiency. Okay, LAD, and then this is chronic granulomatous disease is because of the inability to kill catalase positive microorganisms. Defect in the production of oxygen. So they are just granulomas are there, but they are not can phagocytize but cannot kill. One is X-linked 3 autosomal recessive, one more most are males. Okay, and neutrophils do not produce hydrogen peroxide, yes, which actually acts as a substrate for myeloperoxidase. The organism catalase positive and organism hydrogen peroxide is metabolized and the organism survives. While catalase negative organisms survive. Variable age on onset and severity recurrent abscesses S. aureus and then S. marcescens, B. Typhasia, Aspergillus, C. albicans, Cardia. So inflammatory process are hallmark to pyloric outlet obstruction, bladder, urethral obstruction, rectal fistulae, gangliomatous colitis. Flow cytometry using DHR. Dihydrorhodamine. Oh, okay, so we were using the rhodamine here. Okay, we are not using the NVT. This will help us in chronic granulomatous disease. Yeah, only cure is stem cell, and then others are interferon to reduce the serious infection. Other immunodeficiencies are CDH, gashi, AR, xenokin, oculocutaneous albinism, and prolonged bleeding time, peripheral neuropathy, and recurrent infections. Okay, cutaneous albinism. Like if albino, this is actually albinism. So if you find it in a girl, so this is most probably autosomal recessive. And it might be celiac gashi. So I just don't know lymphoproliferative and complement deficiencies are there. Total hemolytic, like, all components, and then the only significant term, I don't think this we have to read this much. Complement deficiency, high incidence of pneumococcal and meningococcal infection. Yeah, complement I we read this thing. Like we'll just do the only significant one in terms of number of people is ineffective number of effective C1 and so this can be the then we are going to graft versus host disease, major cause of morbidity, mortality after allogenic stem cell transplant, caused by engraftment of immunocompetent donor lymphocytes and immunocompromised host. It shows histocompatibility differences with the donor lead to donor T cell activation against recipient major or minor MSC antigen. Acute and chronic. Acute is in 2 to 5 weeks post-transplant. Chronic develops or persists greater than 3 months after transplant. Major cause of non-relapse morbidity and mortality in long-term transplant survivors. The acute is like we will have this erythematous maculopapular rash, persistent anorexia, vomiting, diarrhea, abnormal liver enzyme. Primary prevention is with post-transplant immunosuppressive drugs and corticosteroids. Okay, so primary prevention we have to do. Chronic is disorders of immune regulation, autoantibody production, increased collagen deposition, fibrosis, signs and symptoms of autoimmune disease. So if we are getting this rash and persistent anorexia, vomiting, diarrhea, abnormal LFTs, then yeah, this is something like this is acute. Chronic is like more very insidious sort of process, very gradual. That concludes our um, chapter 10. Okay, so we have a less, I think not a full lot of chapters are left, and those chapters that are left are not very, I should say, high yield. So I'll just see what I has. We can just go through the I and do it tomorrow, I think, in the next video. Okay, I'm just stopping it here. Thank you.